हॉस्पिटल। तो चांद भी हैरान दरिया भी परेशानी में है, चांद भी हैरान दरिया भी परेशानी में है, अक्स किसका है कि इतनी रोशनी पानी में है। तो ये हमारे स्पीकर्स और चेयरपर्सन के अक्स की रोशनी है जो फैली हुई है। I would like to welcome all the eminent speakers and chairpersons who, amid their heavy duties, burden, and responsibilities, came here to dignify and magnify this meeting. As you all are well aware that earlier this meeting was planned for physical meet and everything was finalized, but due to rapid upsurge in COVID cases, we have to conduct this scientific CME on a digital platform in line with the social distancing norms due to COVID-19 pandemic. You all must be aware by now that the theme of this conference is the prevention and management of common medical problems in day-to-day practice. And यकीन मानिए आज की इस वर्चुअल साइंटिफिक मीट आपकी जीवन की सबसे बेहतरीन वर्चुअल मीट होने वाली है। I will just brief you regarding proceedings. So there will be 6 topics and each topic will be 15 minutes followed by 5 minutes of discussion with chairpersons. And during this time, we will take the questions of audience from chat box only, and then we will move to the next session. There will be question and answer session for 20 minutes at the end of the CME. I'm very hopeful that this meeting is going to be exciting, educational, and full of learning for each of us. There are 2 main announcements. Number 1, each and every participants, speakers, and chairpersons and delegates are requested to mark their attendance by putting their name and mobile number in chat box. And in last of the meeting, based on the number of entries, there will be lucky draw and surprise gifts from BLK Max, which will be delivered directly to their home address. The another announcement is that for each and every participants, we will be entitled for e-certificate issued by AIIMS Gorakhpur in association with BLK. So please don't forget to put your name and mobile number in chat box. So with this now, ladies and gentlemen, it's time to tighten your seat belt as it's going to be very, very tight schedule and we are committed to start and finish on time. So for the first session, I would like to invite our city's 3 stalwarts, Dr. Babita Shukla ma'am, Dr. Deepti Chaturvedi as a chairperson, and Dr. Pooja Nathani as a keynote speaker of the topic, which is excessive vaginal discharge, what a general practitioner should know and how to approach. So Dr. Babita Shukla ma'am, next slide. Dr. Babita Shukla ma'am is a well-known gynecologist and obstetrician who has special interest in high-risk obstetric cases, fetal medicine, and obstetric ultrasound. She is having experience as an ex-resident NLHM Medical College, Ahmedabad. She had been consultant in Gynae and Obst at Sampurna Clinic, District Hospital, Gorakhpur.
Oh,
Experience of
it's not my CV. You are reading out someone else's. You have just this is Pooja's CV, I think, or what? I don't know whose CV is it.
Ma'am, it's mine.
It's yours.
Yes, ma'am.
It has been jumbled. A part of it is mine. I don't know.
Okay, not a problem. Okay, so Dr. Babita Shukla is basically is MS in Obst and Gynae, and presently she holds a very reputed post of Vice President, Obst Gynae Society. She is Secretary to Women's Doctor Association, Gorakhpur. She is Scientific Secretary to ISOPARP, Gorakhpur chapter. The next of our chairperson is Dr. Deepti Chaturvedi. She is a well-known gynecologist and obstetrician who has a very special interest in high-risk Obst, fetal medicine, and Obst ultrasound. She's having very reputed post on. She is a member of Association of Gynae Oncologists of India, state chapter. She is head of IMA Women's Doctors Wing, Gorakhpur. She is a head of IMA Mission Pink Health, executive member of IMA Women's Doctors Wing, state chapter. She is past vice president of Gorakhpur Obst and Gynae Society, member of Indian Menopause Society. She is joint secretary of Indian Society of Perinatology and Reproductive Biology, and she is past scientific secretary and cultural secretary of Gorakhpur Obst and Gynae Society. So now I would like to ask Dr. Babita Shukla ma'am to introduce our speaker and to start with the first session. Thank you, ma'am.
Thank you, Dr. Shahi, for giving me this opportunity. Today, I feel highly privileged and honored to be part of such an important scientific session. The first talk is by Dr. Pooja Nathani. She will be talking on excessive vaginal discharge, a general practitioner's approach. Dr. Pooja Nathani is consultant Obst and Gynae, Tamanna Medical Center, Gorakhpur, one of the most renowned gynecologists and obstetrician doctors in city, and she has been serving offer to end-to-end treatments to her patients. She has done her MBBS from Kanpur and MS from NHLM Medical College, Ahmedabad, her PG diploma in ultrasound. She is ex-resident NHLM Medical College, Ahmedabad, and consultant Obst and Gynae at Sampurna Clinic. She has received fellowship in IFCPC, International Federation of Cervical Pathology and Colposcopy from WHO, a fellowship in Infertility Management, Institute of Reproductive Medicine, Kolkata, and active in District Hospital, Gorakhpur, through cervical screening program procedures. Warm welcome to Dr. Pooja Nathani.
नहीं ये पूरा हुआ था मैं बंद कर दिया था फिर वही
Respected seniors and my dear colleagues, I'm highly obliged to be here on the screen to discuss about excessive pervaginal discharge, what a general practitioner should know and how to approach. Abnormal vaginal discharge is quite a frequent complaint of women met in day-to-day practice of a gynecologist and even our general practitioners. More often, it is related to phobia, related to cervical cancers, and they are ready to undergo hysterectomy even without investigations and treatment. Here, let's talk about leukorrhea. Is it normal? Normal versus abnormal? Causes of vaginal discharge, diagnosis, treatment of common causes, and syndromic approach to vaginal discharge.
Ma'am, will you share your PPT also? Will you share your PPT? We are not able to see.
Yes, I am sharing.
Yeah, kindly share again.
No, share screen. Your PPT is not visible.
Kindly share again.
अब आ रहा है?
नहीं, तुम share screen करो.
Share screen button. Can you see?
Yes.
Yes.
Share your screen and open your PPT.
Yes, ma'am.
ठीक है ये तो है शेयर कहाँ हो रहा है
If there is any problem, you can share your slides with us. We can share.
Yes, share your PPT with Dr. Shahi and he will do share screen.
मैम अभी भी नहीं हो रहा?
नहीं, कुछ नहीं दिख रहा है. तुम अपना PPT डॉक्टर शाही को भेजो मेल में या व्हाट्सएप पे किसी में ही भेज दो. By the time you continue speaking, just
Have you clicked share screen button?
share screen green color का दिख रहा
Green
है.
color button.
Don't worry, Pooja. We have enough time.
Yeah.
Don't worry.
यहाँ से मिनिमाइज करिए मैं व्हाट्सएप कर दूँ क्या है
प्रकाशन चाहिए यार
हाँ कहीं तो अभी बनाया अभी अपने रिसेंट खोला हुआ है। ठीक है, ये दूसरी प्रेजेंटेशन है, बढ़िया नॉर्मल सर्विस पर स्पेकुलम
Pooja, just share your PPT with Dr. Shahi. He will share the screen.
Send me on WhatsApp or email. I'll do it from my end.
Yeah.
It will take hardly 3 minutes. Don't worry.
डेस्कटॉप पे है ना,
अल्टर कीबोर्ड पे अल्टर और एस दबाइए। अपने कीबोर्ड पर एक साथ अल्टर और एस दबाइए। शेयर स्क्रीन अपने आप सामने आ जाएगी।
Pooja, I request you to close all your other windows. जो भी विंडोज आपने अलग खोल रखे हैं वो सब बंद कर दें।
मैंने भेज दिया।
प्रकाश, मैंने तुम्हें सेंड करा है।
व्हाट्सएप और ईमेल क्या किया है?
व्हाट्सएप पे।
स्क्रीन आई नहीं था, पता नहीं कहाँ गया।
कोई बात नहीं।
अल्ट्रा क्या बोले?
अल्टर प्लस एस ट्राई किया क्या आपने? 1 सेकंड का काम है। यू हैव टू प्रेस अल्टर एंड एस टुगेदर। एस फॉर शिवा। ALT प्लस
ALT और S
एक साथ।
शाही, तुमको मिला प्रेजेंटेशन?
I'm just downloading it.
Okay.
वो भी नहीं हो रहा है, बड़ा भी नहीं। वो भी कर दिया, वो अल्ट्रा प्लस एस। तब से मैं आप लोगों से कह रही हूँ, मैं करा थी।
कोई बात नहीं, कोई बात नहीं।
Can you see it now?
Yes.
Yes.
Okay. So
Let's
go ahead.
Let's talk about excessive per vaginal discharge, what a general practitioner should know and how to approach. Abnormal vaginal discharge is quite a frequent complaint of women met in day-to-day practice of a gynecologist and even our general practitioners. More often, it is related to phobia, related to cancers, and they are ready to undergo hysterectomy even without investigations and treatment. Here, let's talk about plechoria. Is it normal? Normal versus abnormal? Causes of vaginal discharge, diagnosis, treatment of common causes, and syndromic approach to vaginal discharge. Let's talk about normal vaginal secretions. A dynamic equilibrium exists between the intact stratified epithelium, normal colonizing organisms, and local secretory, hormonal, and cellular immune factors. Vaginal secretions are composed of vulvar secretions from sebaceous, Swiss, Bartholin's, and screen glands, transudates from vaginal wall, exfoliated vaginal and cervical cells, cervical mucus, endometrial and oviductal fluids, microorganisms and their metabolic products. Normal vaginal pH is less than 4.5. What is the normal flora of vagina? It consists of lactobacilli. It is found in 96% of the women. Protective effect is by interfering with adherence to epithelial cell. Facultative organisms consist of diphtheroids, streptococci, E. coli, Ureaplasma urolaticum, and Mycoplasma hominis. Anaerobic organisms are Peptostreptococci, Bacteroid, Fusobacterium. Types of vaginal discharge. They can be physiological and pathological. Pathological causes include infective and non-infective etiology. In infective causes, we can talk about bacterial vaginosis, candidiasis, trichomoniasis, gonorrhea, chlamydia, and herpes genitalis. Non-infective causes include foreign bodies, cervical polyps and ectopy, genital tract malignancies, fistula, and allergic reactions. Because we are more concerned for our general practitioners, we will talk about only common causes of discharge. In 30% of the patient, it is normal discharge. 23 to 50% of the cases, it is bacterial vaginosis. 20 to 25% of the cases, it is Candida vulvovaginitis. 5 to 15% of the cases, Trichomonas vaginitis. And in 20% of the cases, mixed infection or sexually transmitted diseases may be the cause. Let's talk about leukorrhea, because patient comes many times with complaint of leukorrhea. What is leukorrhea? It is defined as excessive normal vaginal discharge. It is the excess secretion that is evident from persistent vulval moistness or staining of the undergarments, brownish yellow on drying, or need to wear a vulval pad. It is non-purulent and non-offensive. It is non-irritant and it never causes pruritus. The excessive secretion is usually due to physiological excess during puberty, menstrual cycle, premenstrual pelvic congestion in pregnancy, and during sexual excitement. Cervical causes may include erosion, chronic cervicitis, mucus polyp, and ectropion. Vaginal causes are seen in increased pelvic congestion like uterine prolapse, acquired extroverted uterus, chronic pelvic inflammation, pill use, and ill health. Diagnosis of leukorrhea is based on history, examination, and investigations. Treatment, as it is non-infectious, only improvement of general health is needed. Cervical factors, if there, it requires surgical treatment like electrocautery or cryosurgery. Pill users may have to stop pill temporarily. Hygiene should be maintained. Bacterial vaginosis. It is non-specific or Gardnerella vaginitis. It is most common form of vaginitis. It is an alteration of normal vaginal bacterial flora. Increase in anaerobic organism occurs and facultative anaerobic flora is there. Diagnosis. Fishy vaginal odor and vaginal discharge are diagnostic. Patient usually complains of fishy vaginal odor. Second, homogeneous discharge adherent to vaginal walls. pH is more than 4.5 in bacterial vaginosis. Increased number of flu cells are seen microscopically, and whiff test is positive. Here is a typical picture of bacterial vaginosis, that is excessive white homogeneous discharge. Treatment. Oral metronidazole is the drug of choice. 500 milligram BD for 7 days is given. Cure rates are 75 to 84% for the above regime. Clindamycin ovules intravaginally once at bedtime for 3 days can also be used. No treatment of sexual partner is needed in cases of this bacterial vaginosis. Let's talk about vulvovaginal candidiasis. It is the second most common cause of vaginal discharge. Causative agents are Candida albicans, Candida tropicalis, Candida glabrata. Risk factors include altered immune status, increased glucose levels that occurs in diabetes, decreased lactobacilli concentration, which occurs due to overuse of antibiotics. The whitest discharge of candidiasis varies from thin to curdy consistency, that is cottage cheese-like appearance. Patient usually complains of curdy white discharge in cases of candidiasis. Treatment is vaginal antifungal creams, butoconazole, clotrimazole, miconazole for 7 to 14 days. Oral antifungals can also be used, that is fluconazole in a single dose 150 milligram. But if patient complains of repeated candidiasis, then we can give them weekly for 3 weeks. Trichomonas vaginitis. that is flagellated parasite Trichomonas Vaginitis, most common cause of vaginitis worldwide. Humans are the only host and it is sexually transmitted. 70% of the males get infected after a single exposure to an infected female. This is a typical vaginal discharge caused by trichomoniasis, and strawberry cervix is diagnostic in cases of Trichomonas vaginalis. Treatment again, metronidazole is the drug of choice. Single dose 2 milligram orally or 500 milligram BD for 7 days. Cure rates is 95%. The sexual partner should also be treated in this case. If no response to initial therapy, metronidazole twice daily for 7 days can be given. If repeated treatment is not effective, 2 gram metronidazole once daily for 5 days or tinidazole 2 grams single dose for 5 days should be given. Let's talk about uncommon causes also. They can be atrophic vaginitis, infectious cervicitis caused by Neisseria gonorrhoeae, chlamydia trachomatis, herpes simplex virus. Vaginitis or vulvitis can be due to vaginal or vulval trauma, irritant contact dermatitis, vulvar vestibulitis, cervical polyp and malignancy. As we are more concerned for our general practitioners, I am not going to discuss about management of uncommon causes as it is a vast subject. Let's talk about syndromic approach that can be useful for all of us. Syndromic approach. The management of patients presenting with vaginal discharge depends on the availability of speculum and laboratory facilities. If a woman presents with complaint of vaginal discharge to a health facility where even a speculum is not available, she and her partner are treated empirically for gonorrhea, chlamydia, candidiasis, trichomonasis, and bacterial vaginosis, that is with metronidazole. If speculum is available, treatment is given according to the nature of discharge. If it is mucopus, treat for gonorrhea and chlamydia. If it is profuse discharge, treat for trichomoniasis and bacterial vaginosis. If it is clumped discharge, treat for candidiasis. If the partner has lesion, the couple are given treatment for gonorrhea and chlamydia as well. Take home message. I would like to say that after general assessment, age, history of type and color of discharge, if general practitioners thinks it is normal excessive, that is leukorrhea, they can treat accordingly. If no relief, even after 4 or 5 days, or they are suspicious of some malignancy or some severe infection, it is better for her to go for a gynecological consultation to prevent unnecessarily complications which can be prevented by timely intervention and treatment. Thank you.
So thank you, Pooja. Thank you for your wonderful presentation. And the session is open for discussion among the chairpersons and speakers. If there are any questions in chat box, they can take the question. I request Dr. Deepti ma'am to...
Yes, there is only one question written by 2 people. And they have asked, what about the kits that are available, combo kits? Can we use them or should we treat according to, as you have said?
Ma'am, they should be treated according to the complaints. We should not use the combo kits frequently. Like if patient complains of discharge, we should not give combo kits.
Absolutely. I would like to add a bit. You are very rightly said. But as we had many CMEs with our seniors, they had come to conclusion that this is a developing country and those things which you have said are very right for the developed world. So here we don't see the details about the discharge and we can use the combo kits, though it should be done exactly as you have said, very rightly said. But this has been told by our seniors that because it's allowed in developing country, that where you will go for those tests, each and every separate, and get it done and analyze. So you can do it that way. take the combo treatment if she has some itching or some other clinical symptom along with this. So this is it. Anything else you want to say?
Dr. Babita ma'am, if you want to add something. Ma'am, mute yourself, please. Please mute yourself.
Unmute,
Yes.
please. Babita?
So, yes. Discharge PV is, I think, one of the most commonest complaint that we see in our day-to-day patients in an OPD, be it gynecologist or physician. I mean, almost everyone. If a lady comes in the reproductive age group, that is a most common complaint. We should not take it lightly. A proper thorough history and examination is needed because we have to rule out between physiological and pathological discharges. The timing of the menstrual period is important because there is an increased discharge during the peri-ovulation period, just before menses. The increased discharge with the take of OC pills. So drug history is also important. And then in the, like if the patient is in the perimenopausal period, then apart from infection, we can think of other causes like atrophic vaginitis. So the age of the patient is also important. Then, as Pooja has clearly mentioned, depending upon the type of discharge, like we are having copious discharge, and then we think of trichomoniasis and bacterial vaginosis. Bacterial vaginosis has got a typical fishy odor, like you said. And candida infection, we get discharge, which is curdy white discharge. So on the type of discharge. Now, see, the discharge could be from the vulva, it could be from the cervix, it could be from the vagina. We have to differentiate. But what is happening is nowadays, if you get cervical lesion or like it is erosion or something, people take it very seriously, and we are seeing so many cases of hysterectomy these days. I'm seeing so many prescriptions where hysterectomy has been advised in young
But
females.
that is
So
criminal. We shouldn't do. Yeah.
No.
That's criminal.
So we should have a rational approach.
Because
We
we
should
are
not
more
be
concerned for our general practitioners.
Yeah.
That's what.
For saving the uterus,
How
that is
can
more
they
important.
diagnose whether it is cervical erosion or infection?
Yeah. If they can do, they should do a PS and check. But because mostly
they
they
will
are
refer to us. They cannot do.
Our society.
They cannot
they
do.
won't
They will
do.
refer to us. What I want to say is that is the thing that, like what we are seeing, even in not only gynecologists or even the general practitioners, because of repeated discharge PV or recurrent discharge PV, the patients are having a high incidence of hysterectomy. So our message should be that it should be rationally analyzed before we come to any conclusion. That's all.
Okay, thank you.
Hysterectomy should not be done for PID or discharge PV.
Yes.
This is written by Dr. Ankita Kumari.
Yes.
Good.
Okay,
And
thanks.
Dr. Shiv Shankar Shai is asking, can IMA do anything to prevent such type of surgeries?
Yes, IMA should be, I mean, we can give articles in newspapers or magazines regarding the conservative management of discharge PV. Like hysterectomy is the ultimate treatment after all all the treatment options are failed, and it is a life-threatening risk to the patient.
Nowadays
Uterus should not be taken so lightly. Like
so lightly. Even
I have
for
come
menstrual.
across patients who have gone hysterectomy done for vomiting, pain in abdomen, loss of appetite, and even loss of hair loss also. So
Absolutely.
I mean, we should not take it lightly. We should rationalize that decision. Yes.
Actually, it shouldn't be
IMA
done
is
even for
not only IMA,
menstrual.
even Foxy, both of them. We
Menstrual
should send
irregularity
articles in
can be
newspaper
achieved.
and in any form of social media that hysterectomy is not a job to be done so easily.
So it should not be done routinely, and even for menstrual irregularities, unless it's not being controlled by the other methods like Marinati or Cabergoline, Lupride, and there are many cases accordingly we treat. And unless and until the gynecologist herself says, yes, this is ultimatum, and you have to get surgeon shouldn't do hysterectomy, and even the gynecologist shouldn't do. The gynecologist also should only keep it as a last resort. Shouldn't do it routinely.
Okay, I think it was an excellent oration by Dr. Pooja Nathani and a great discussion among the chairperson, Dr. Babita Shukla and Dr. Deepti Chaturvedi ma'am. And now I think it's time to move towards our next very interesting session on noise pollution and its effect on our daily life. And to chair the session, I would like to call upon Dr. G.N. Lal sir and Dr. P.N. Jaiswal and Dr. Ruchika Agrarwal as a keynote speaker. Dr. G.N. Lal sir is an renowned ENT surgeon and he's practicing in Gorakhpur for the last 23 years. He did his MBBS from BRD Medical College, Gorakhpur, and his MS ENT from AIIMS, New Delhi. He's a senior resident in Sitaram Bhartiya Medical Institute, New Delhi, and he did his post-DM senior residency in interventional, I think it's wrongly written, sorry. Yes. And
anyway, continue.
Guest lecturer in BRD Medical College, Gorakhpur in ENT practice for the last 23 years. So next are Dr. P.N. Jaiswal. He's having more than 10 years of working experience with special interest in otology, neurootology, and especially he's having interest in head and neck and skull-based surgery. And he did his MS in ENT from KGMU, Lucknow. He has been an ex-assistant professor, Mayo Institute of Medical and Sciences, and ex-consultant ENT Guru Shri Gorakhnath Hospital, Gorakhpur. And so with this, I'd like to ask Dr. G.N. Lal sir to introduce our next speaker, Dr. Ruchika Agrarwal.
Thank you, Dr. Shahi. Am I audible?
Yes, sir. You are well audible.
Good evening, everybody. First of all, I would like to thank you all for making me to chair this session. The next lecture in the series is by Dr. Ruchika Agrarwal, who is assistant professor in the Department of Otorhinolaryngology in AIIMS, Gorakhpur. She will be delivering a small presentation on noise pollution and its effect on our daily life. Can we have the PPT about the biodata and brief introduction of Dr. Ruchika? Is it there?
Sir, it's on the monitor, sir. You can see
It's already there.
It's already
Okay.
there. Sir. Can you see?
Dr. Ruchika doesn't need any special introduction because she is born and brought up in Gorakhpur and is doing very well. She did her MBBS from KGMU Lucknow and then MSc from KGMU Lucknow. She did her senior residency in AIIMS New Delhi, and she is having special interest in oral oncology. Over to Dr. Ruchika for her interesting lecture on noise pollution and effects on our daily life.
Thank you so much, sir. Thank you for such a nice introduction. And thank you, Shai sir, and the IMA team to invite me for this presentation. I'll start my presentation. So a very warm New Year, Happy New Year to everybody. So we are talking about noise pollution and its impact on human. I would also touch about what and how it affects us as doctors and how we should be aware in working around in noise. So noise pollution is an invisible, odorless, and very much ignored sort of pollution. And in this short time, what we'll be talking about, just a brief on what is the problem, why should we as doctors know about it, and what can we do about it in our own small ways. So what is the problem? When do we call something like noise? Noise are any sound vibrations that are unpleasant or disruptive to auditory system. Now, unpleasant means it has a psychological component in it, and disruptive, that means it has a pathological impact on our body. To auditory system of whom? Auditory system of whom? Like some noise which is unpleasant to some other animal may be pleasant to us. So when it is generally talked about noise pollution in various environmental studies, we also talk about pollution for animals. I will just briefly give some insight on what studies are being done in environmental science to make us aware. So this is what noise is, and we are just talking about acoustic noise. There is a lot on electronic noise and various other things that comes into noise, but we are just talking about acoustic noise, that is sound vibrations. So what is or any substance or energy which is not dispersed, diluted, recycled, or stored in a harmless form for the environment is caused by pollution. And we are just talking about anthropogenic pollution, that's by humans. My slide is not moving. Sorry. Okay. So where do we get this noise from? There is general urban noise from chats, from talks, from our utensils, from everyday everything moving and all this. That's a small noise, but collectively it accounts a lot. Then there is a huge lot of transportation noise, right from air travel, from transportation on road, where the water travel is there, not exactly in our city, but around many cities. And now that water travel is being more promoted through the government of India, they have plans. So we can expect that sort of noise pollution also increasing in our neighborhood. So then there is industrial noise, which is from construction, big machineries that are going around, and recreational noise, loudness of which can be painful at many times. Military noise, only usually the army are more affected, but and the areas nearby are affected. It's not so much in happy also. And then there are small noises like some vibrations, some our notifications on mobiles, all these things, small noises, or everything, it contributes to our noise pollution. It's so slow. So now coming to magnitude of the problem. So it is a problem, but how much? How do we quantify it? What do we think? So WHO in April 21, they have given an estimate that by 2050, 2.5 billion people will have some degree of loss, and at least 700 million people will require hearing rehabilitation. That means some sort of hearing aid or some assistance for hearing rehabilitation. And that includes all age groups. But unfortunately, even if we expect so much of hearing loss, we are not recording how much the noise pollution is. It's a very easy process that how we can record it, but still we are not very much aware, and nobody is doing that. Even in European countries, the only very good study that is in 2011, that says 40% of population in European countries are exposed to these road traffic, not healthy for them. In India, after the Supreme Court order, the Central Control Board, Pollution Control Board, that yearly records 251 locations, at 251 locations, the Deepavali pollution. And for 2020, what has been published, 2021 data is yet to be published, but 2020 data is 33 to 97, lowest and highest in Diwali, and 32 to 87 in this pre-Diwali day. And this is just only, the whole thing is being done only for the Diwali, only after the Supreme Court order. They do have a proposal of having many more continuous monitoring, but still the things are not in place, and we do have a lot of discrepancies and in this thing. So just sorry. Okay, now this is a 2017-18 picture. It is actually given by one of the audiological service provider. So we have to be a bit skeptical about how we interpret it, but still India scores very poor in how we hear. The data is not so robust, but still India is poor even in that. So we have to be very sure what we are hearing, how much of awareness do we have in all these things. So again, it's moving very slow. I don't know why. Okay. So as we know that this is a problem, now why should we know about it? How does it impact us? So before going up on how this impacts us, I'll just talk about some studies done in environmental people, and they have seen, just see this audiological frequencies, the anthropogenic noise made by the ships, by instruments in the sea, is almost equivalent to what vibrations the mammals in the sea they work in. So this affects the distribution, the fitness of these living beings, their communication, their area which they are predominantly placed. So all this thing is disturbed by the noise produced by these things, these huge ships and industrial noise that are produced in the sea. In lockdown, what we have seen and people have recorded that a lot of species which were less seen or spotted, they actually appeared a lot. That I'm sure many of us have seen some videos of dolphins in the seas and Italian canals being clear, and everybody has actually observed these things on personal note as well, that we have seen clearer air, less noise, and a calm feeling during the lockdown. So it was not only about air pollution, it was also about noise pollution. So now this is another study. What's the problem? Okay. I'm pretty sure many people must be thinking why I'm also talking about these animals and all. So this study, it was done in 2021, it was published in 2021. So this study is done on birds and their learning. So in a noisy environment, the result was the learning of how food and area where their food was hidden. So 80% of the birds which learned the place in a calm environment, they responded positively, and 30% they missed the point. So this study actually indicates that there is some difference in cognition as well, in memory as well. Is it happening to us as well? So this is the study. Shit. Is it okay that I play it in non-slideshow mode? Because somehow this movement is getting very slow. So in this study, it has actually proven that this is a systematic review and it has just been published in Environmental International. So after studies, many studies, they have actually proven that children have a reading comprehension score in a quiet classroom were 0.8 points higher than the children in the noisier classrooms. So this noise is actually affecting our children. And not only our children, the cognitive impairment of the people aged 45 plus in a higher residential noise exposure, the odds were 1.4. So again, we have to be aware of all these things. It is affecting us. It's not only affecting the birds and animals and all those things. We have to be aware because it's actually hitting us. So how does it hit? Does it hit only on cognition? What are the other non-auditory effects? There is sleep disturbance. There is blood pressure changes. There are cardiovascular diseases. There are adrenaline and increased adrenaline, non-adrenaline levels, and annoyance and the psychological effect everybody has felt. Once you get up in a morning or see in a very calm place, your psychology already it changes. You have a calming effect. So with noise, as we increase, go ahead with our daily activities, we see increase in noise, and that has a psychological effect. While people can actually comment on how these studies were done, many of the studies, though I have mainly quoted many systematic reviews, many of the studies have been done on airports, which have a very high noise ratio. So they are quite genuine and reviewed very nicely. So what is the damage we see? And it has also been proven on microscopy. It's not only on observant study as we see in pure tone audiometry, which is very subjective to the patient. Electron microscopy has also shown there is noise-induced hearing loss damage. The noise-induced hearing loss is damaged here in the outer hair cells. On conofocal microscopy, the synaptic ends decrease has been proven. So there is things that is proven. It's not something that it's a psychological effect. They have these effects and that has been proven. So now we are coming on how these noise pollution points affects us. Hospital, wherever we work, oh, I'm so sorry, I'll just rush it now. So hospitals wherever we work are supposedly to be a very quiet place. And just see at what level we are working. This is the study from Mumbai, which says mostly the hospitals are working at 95, 97, 100 dB. And on the contrary, the hospitals of London are having much quieter place. It's not only in Mumbai. The study from PGI Chandigarh, this shows even the library is past the recommended level of loudness or recommended level of noise, even in library. So just forget about any other place. Even in the library, it's not at the level of recommendation. PNJVOS is in OT, and this is for all surgeons. In OTs, we have a noise level of around 100 dB in 50% of the time. And the peak noise, this study was from a neurosurgical and ortho OT. So this peak noise, mainly it is by drill and suction machines, which goes up to 131 dB. And that has very close thing to a pain threshold. So we are bearing with all this. So we have to be very aware of it. Impact of noise in operation theaters, it not only affects our performance, our communication with the teams, and it also affects our psychology. Especially it irritates so much that unknowingly we are very much at risk to commit some other negligence or some process, some trauma to the patient, unwanted trauma. These things can happen. So we have to be aware how much noise we are living in. So in a hospital setting, what are other noise that we come around? The vehicles that come, the ambulances, people in the crowd, our speakers, the phone, the TV that we use. It usually is on a very high volume. So these things are there. We have to be aware. So now we know that there is a problem. We know that we are living with this problem night and day. So now what we can do about it? So there has to be an awareness attitude. The whole point of this lecture is only on awareness. Once we know that we are having some problem, I'm pretty sure we'll think of some solution, as the solutions are right in front of us. It's not something, it's not available in the market. Everything can be solved once we know that this is a problem. So awareness attitude, prevention, diagnostic and curative is a part of ENT surgeons. Rehabilitation is there, and research again is a part of institutionals and things that we are in, obviously in combination with the environmental people and the medical researchers, so that we can develop better living space. So first and foremost, awareness. Sound is measured in decibels, the loudness of it, which we are mainly concerned. The permissible level for commercial place is 65 dB. At night, it's 55. Residential, it's 55. So on an average, if we say, if we are below 65 dB at any time, we are safe. That is what we can say. And where do we live? This is this thing. We have a sound level meter. We can easily have on our application. Google Play Store, iOS, both of them have these apps. Can actually record and tell you live that what is the sound that we are actually sitting in, anywhere, anytime. We all have these phones we can use, and we can measure the noise in which we are working. So I suggest all our surgeons, especially because we are operating with drills, we are operating with suctions and all sort of machines, even the anesthesia machines, they have these constant reminders, and that is a noise. It's essential, but there is a noise. So how can we do about it? We have to think about all that. This is a chart easily available on net. I'll just take a lot, skip some slides. And that how much noise, how much dB, which noise is there. So a hair dryer has a 90 dB. So we can compare with that. Most of the ladies, I guess, have this thing in their usual thing. So it's a 90 dB, and the exposure time there is 80 dB. It should not be more than 8 hours. So beyond that, it goes exponentially down. So 130 dB, 130 dB, what we say is the noise of the drill machine, what we are using. It should not be less than 30 seconds. And PNJ boss, I'm pretty sure we work for more than 2 hours in that. So we have to be aware how much noise we are in, how much harm we are doing to ourselves and our team as well.
Dr. Ruchika, you have 2 minutes more.
Okay, thank you so much, sir. Thank you for the time. I'll not take much time. So once we are aware of how much noise we can use the simple apps. And now we know the source from where the noise is coming. We are the receiver, and there is a straight path. How can we stop that? We can modify the source, we can redesign source, and we can also think of options if we can relocate the source. If we cannot do that, if the path is direct, so we can think of enclosures, absorption options, and reducing some barriers. I'll just give some options of that. So there are enclosures. We all know the old generators we used to have, which make so much noise. Now we have a compact generators, so they have an enclosed sound piece. There are fabric enclosures as well, so it can hide the whole noise, whatever noise is being produced. Very important point is, while getting construction done, how much noise is we are having. So we can have absorbent tiles that absorb. It is a part of engineering, but we can think of it wherever construction is being done around our hospital. Similarly, there is these tiles we can fill in. These are microwool forms that are absorbent. There are sound absorbent, and they come in a very beautiful forms as well. So it won't affect the aesthetics of your hospital or your home. So we can do that as well. We just have to be aware, and we have to ask our architects or engineers that we want a low noise level in our homes and in our hospitals. So it is just what we ask for. They come in a very beautiful shapes, as simple as these rubber. These are very cheap, 100 rupees or something, a roll, meter roll. We can place these strips, rubber strips, on our doors, where we can avoid the noise moving from the side, from the below of the doors. Then we have vacuum glass doors as well, which is available. That also avoids this traffic noise which we are having. So then the diagnostic part is, these are the preventive things, and there is lot many we can always search once we know how much noise we are living. And once we are determined that we want to live in a quiet place, we want to improve our health and our dear ones' health. So this is can go how much harm it done. In creative part, there is an acute exposure of noise, especially like Diwali or some other machines. So we can have steroids for that for a short term. Other than that, there are multiple medical options. And, gene therapy is also being explored for this. So diagnosing that this, so we can have hearing rehabilitation in form of hearing aids, implants, and other languages. So let's not go much in that. What I'm going to talk about mainly is we can use our smartphone apps that measure ambient noise, whatever noise we are living in. We keep them up to 60% of maximum volume. Most of the phones and the apps are now showing that an alarm on higher volume, and more than 60%. They do.
The timer, your screen sharing is going to get stopped. So just conclude your presentation. Sorry to interrupt.
Okay. Is better, and take acoustic breaks, soundproofing. one or two slides, not much, not too much, I guess, to make some noise for silence. That's what the message I want to go for. Thank you so much.
Thank you, Dr. Ruchika. Very good talk about noise pollution and how it affects our day-to-day life, especially the doctors. I'm having a silent rhino suction is there. It is not central suction as Sai boss has said, but it has significantly low noise. Basically, it is for the debriders. One thing I will also like to add, there is a term ringxiety. Often we feel that our phone is ringing, and actually it is not ringing. So it has very much prevalent in our day-to-day life. We keep on taking out the phone from our pockets and seeing that whether it is ringing. So it has caused a type of psychological problem also. Anyhow, thank you very much. Very nice talk. Any questions?
Can I intervene, Dr. Alok?
Yes, sir. Go ahead, sir.
Dr. Ruchika,
Asking some question again.
No, I have some suggestions to give. No, I will not ask questions from you. It was a very beautiful presentation. आपका लेक्चर सुनते सुनते कुछ लाइनें मैंने लिख डाली, वो मैं शेयर करना चाहूंगा। संगीत जब शोर हो जाए, ऑप्टिमम जब समथिंग मोर हो जाए।
वाह वाह।
संगीत जब शोर हो जाए और ऑप्टिमम जब समथिंग मोर हो जाए, सुखद की जगह बोर हो जाए। समझ जाओ मित्रों और समझ जाओ मित्रों, कम करो डेसिबल, बंद करेगा यह साउंड स्ट्रेस का बेल। तो मैडम सबसे बड़ी बात यह है कि साउंड इज ए फिजिकल स्ट्रेसर एंड ए स्ट्रेसर व्हेन इट becomes from eustress to distress level, it will create problems that we all know. The main thing is that how to reduce that sound stress. We have given some good suggestions. My one thing is that all those who are working in ICU and ICCUs, whenever I go in an ICCU, there is always a bell, dong bell always ringing there, ton, ton, ton. And that I find very irritating, very irritating. I don't know how those patients who are there in the ICU, they tolerate it. If somehow this can be tackled, I think a lot of stress from the indoor patient of ICU will be weaned off. Those who are working in ICU, they can put their own views on this continuous hammering sound which comes in the ICU and ICCUs.
Thank you
very much, sir, for the nice share, and thank you, Dr. Ruchika.
Thank you so much. I think it's time for ourselves moving towards our next session. And before moving to next session, I think there is some message from our AIIMS president. I invite Dr. Shiv Shankar Shahi to have message for the AIIMS members. Boss, go ahead, mute yourself. Just in brief. Boss, mute yourself. Unmute yourself, please. Shahzad. Yes.
Thank you, Dr. Prakashan Sai. Can you hear me?
Yes, yes, yes. Go ahead, boss.
Yeah. Most welcome, all respected my seniors and AIIMS members. And I welcome BLK Max team, Dr. Sushant, Dr. Dharma. They are going to present their topic in very few minutes. This is very dynamic. Scientific Secretary Dr. Prakashan Sai, you are doing well, and I think it will continue after that. Today you are on the webinar, but hope in future just we plan to make our IMA Bhavan. Our dream project of each and every IMA member from Gorakhpur कि मेरे पास एक IMA भवन बनने वाला है जहां ये सारी सेमी होती रहेंगी हमेशा। IMA भवन का निर्माण चालू हो चुका है और पाइलिंग का काम लगभग हो सकता है 5 या 6 फरवरी को खत्म हो जाए, फिर मेरा भवन ऊपर आ जाएगा। और एक सपना है कि होली के बाद कभी हम अगर CME कर रहे हैं तो उस IMA भवन में हो, उस बड़े हाल में हो, ताकि एक साथ बैठकर हम लोग मिल सकें। अभी थोड़ी सी बाधाएं आ रही है फंड कलेक्शन की। मैं जो जमीन खरीदने में जो लोग पैसे दिए थे उनका नाम डिस्क्लोज किया जा चुका है, वो चाहे तो और शेयर कर सकते हैं और IMA के सारे सदस्य जितना से जल्दी अपना कुछ अनुदान देंगे, IMA भवन उतना जल्दी उतनी तेजी से आगे बनकर सामने आएगा। ये सिर्फ एंड सिर्फ हमारे सदस्यों के लिए हम लोग का ड्रीम प्रोजेक्ट है। और जो सीएमई हमारी आज जो बाहर की आती है, जो फैकल्टी आती है, जैसे आपका बीएलके मैक्स आ रहा है या मेदांता आता है या पोलो आता है, इन सबकी सीएमई वहां की जाएगी। अगर ये लोग भी चाहें, मैं बीएलके मैक्स से भी रिक्वेस्ट करता हूँ, ये लोग भी चाहें तो कुछ अपना योगदान अंशदान कर सकते हैं, ताकि एक बहुत ही खूबसूरत, बहुत ही अच्छा आईएमए भवन बनाए, जिसमें अच्छी से अच्छी सीएमई अपने घर में हो सके। मेरा मात्र मैसेज यही था। और हम अपनी पूरी डायमंड टीम को धन्यवाद देता हूँ, बधाई देता हूँ। हमारे साइंटिफिक सेक्रेटरी बहुत अच्छा कर रहे हैं। इनके साथ और जो मेरी टीम है, हमारा आईएमए भवन की टीम है, हमारा बायलॉज कमेटी टीम बनी हुई है। अभी हमारी कोरोना की वजह से जो आईएमए कैंप या हेल्थ मेला की टीम अपनी काम नहीं कर पा रही है। अभी वृद्धा आश्रम हम लोग कम लगाए थे, उन बुजुर्गों को जो घर पे सहारा नहीं पाए थे, कहीं किसी का रह रहे थे, उनका ठीक हेल्थ चेकअप हुआ है। और किस तरह से हम ग्रामीण अंचल पहुंचेंगे उसको हम लोग टच करने वाले हैं। इस तरह से हमारी ढेर सारी कमेटियां, ढेर सारी मीटिंग है। क्योंकि ये संस्था है, संस्था एक आदमी से नहीं चलती, संस्था के सदस्यों से चलती है। इसीलिए संस्था के सभी सदस्यों का योगदान और सहयोग बहुत ही जरूरी है। आप अपनी सेमी कंटिन्यू करें। बस इन्हीं शब्दों से मैं अपनी वाणी को विराम देता हूँ और सबसे हाथ जोड़कर नियुक्ति करता हूँ कि आईएमए भवन में अधिक से अधिक अंशदान सहयोग करें और इसको जितना जल्दी हो सके इसको अपने असली रूप में आने की कोशिश करें। जय आईएमए, लॉन्ग लिव आईएमए।
Thank you, boss. Thank you for your kind words. And now it's time to move to our next session, and I would like to call upon Dr. Navneet Jaipuriar sir and Dr. Sudhir Kumar sir as a chairperson, and Dr. Sushant Srivastava sir as a keynote speaker, and is going to talk on a very, very important topic on heart valve surgery and its implication for general practitioners. So I would like to take this opportunity to introduce our chairperson. Dr. Navneet Jaipuriar sir is a very renowned cardiologist from Gorakhpur, and he's a role model for hundreds and thousands of students and doctors also. And he's the best thing about him is he's always ready to help everyone and everywhere. And his professional recognitions are he's delivered a lot of lectures and he chaired academic sessions in various national seminars. He's having active participation in all the conferences around the city. Next chairperson is Dr. Sudhir Kumar sir. Sir is MBBS from Jaiswal Medical College, Kanpur. He did his MBBS in 1984 and he's completed his cardiology from LPS Institute of Jaiswal Medical College in 1987. And his CCBDM completed in 2017. He's an ex-consultant cardiologist in MP Heart Center, New Delhi, ex-consultant cardiologist from National Chest Institute, New Delhi. He chaired sessions in UPCSI and RSSGI UP chapter. His main interest in diabetes, and he's regularly in touch with the any symposium going on in the diabetes. So with this, I would like to ask Dr. Navneet Jaipuriar sir to please introduce our keynote speaker, Dr. Sushant Srivastava.
Hi, good evening, everybody. It's such a pleasure to be here with all of you. And I welcome Dr. Sushant Srivastava in this webinar and on heart valve surgery. I think heart valve surgery is one thing that I think everybody should know about, because almost everybody, even non-MDs, are dealing with valve diseases. So Dr. Sushant Srivastava is one of the finest heart surgeons in the country with a vast surgical experience. With more than 25 years of experience, he has performed more than 12,000 cardiac cases. He is a versatile surgeon and performs CABGs, valve repairs, replacements, and procedures for complex congenital heart diseases with equal ease. He is MS General Surgery, MCH, CTVS, AIIMS, and training in ventricular assist devices at Philadelphia, USA. And he has been the chief cardiac surgeon at Batra Hospital, senior consultant at Max Devki Devi, Delhi, and is a faculty of AIIMS as assistant professor CTVS. His clinical experience have been profound, performed successful beating heart bypass on the oldest patient in India, 96-year-old, Mr. J.C. Mehta from New Delhi. Performed the first awake CABG in Delhi, endovascular therapy for aortic aneurysms, aortic aneurysm surgery and hybrid procedures, surgery for congenital heart defects, redo valve and bypass surgeries, and complex peripheral vascular and limb salvage surgery. I think, I mean, after reading all this, I really think Dr. Sushant Srivastava has a lot to share with all of us, and I'm sure it will be a wonderful session. Dr. Sushant Srivastava, I'm sorry.
Thank you, sir. Can you hear me?
Yeah, you're very audible. Thank you.
Thank you, sir, for that kind introduction, and thank you for the opportunity to speak to AIIMS Gorakhpur. The topic is heart valve surgery, implications for the general practitioner. And my challenge is going to be fit everything that I want to say in the 10 minutes that I have. Let me try. So we have a large number of...
Sorry, sir, kindly make a slideshow.
Country.
It's not coming as a slideshow.
I beg your pardon, sir?
It's not coming as a slideshow.
You can't see the slides?
Yeah. Slides are visible, but it's not a slideshow.
Slides visible है sir, but slide show में नहीं है. If it's possible, then you can.
यहाँ तो मैंने slide show कर दिया है.
No problem, sir. Kindly remove. Kindly stop sharing.
Okay.
अब दिख रहा है? Can you see the slide show now?
Yes, sir. Go ahead, sir. So now we lost the slides.
Kindly share it again, sir.
Yeah, I think I can see the first slide.
Yeah.
Yes.
Now it is absolutely. Kindly go ahead.
Shall I start?
Yes, please.
Yeah. So the topic is heart valve surgery implications for the general practitioner. We have a large number of heart valve patients in this country. India being a developing country, most of the burden of heart valve disease is rheumatic in origin, to the extent that pure mitral stenosis is 97% likely to be of rheumatic origin. There are other causes of heart valve disease, such as degenerative valve, bicuspid aortic valve, endocarditis, etc. And these all contribute in their own way to the burden of heart disease. Now, the treatment for heart disease is valve replacement. And we have three options for valve replacement. The first and the most commonly used option is the mechanical valve. Now, you can see two kinds of mechanical valves here. The first one, this one, is a tilting disc valve, and the other improved mechanical valve is a bileaflet valve. The second option is a bioprosthetic valve. A bioprosthetic valve is essentially a porcine or a bovine valve mounted on a stent. And then there is the new TAVR valve, or the transcatheter aortic valve replacement valve. And the valve that you see here is made of equine pericardium. There's also heart valve repair for valvular heart disease, but even in heart valve repair, we implant foreign material inside the heart. And here you can see a mitral annuloplasty ring implanted around the mitral valve. So whether it is heart valve replacement or heart valve repair, some kind of foreign material is implanted inside the heart. Now, when we implant foreign material inside the heart, it becomes thrombogenic, and some kind of anticoagulant strategy is required. Let's begin with anticoagulation for prosthetic heart valves. Now, if it is a mechanical heart valve, lifelong anticoagulation is indicated. For bioprosthetic valves, 3 to 6 months of anticoagulation is indicated. And for valve repairs, 3 to 6 months of anticoagulation is required. Now, what happens if you don't anticoagulate a prosthetic heart valve? A clot forms. Clot is very likely to form on the prosthetic heart valve, leading to severe prosthetic heart valve dysfunction. In common parlance, this is called a stuck valve. This leads to serious symptoms, congestive failure, pulmonary edema, and the patient can die if she does not reach hospital in time. In addition, some of the clot can embolize and result in stroke or myocardial infarction or other vital organ ischemia. If we hold anticoagulation, it can cause thromboembolism, which carries a 20% risk of mortality and a 40% rate of major disability. So these are the disadvantages of not anticoagulating a prosthetic heart valve. Looking further at the risk of not anticoagulating, the estimated annual thromboembolic risk without anticoagulation in a patient with a mechanical heart valve is between 8 and 22%. And this risk is dramatically decreased if anticoagulation, adequate anticoagulation with warfarin is undertaken. The risk is decreased by as much as 80%. Now, the mechanical valve or the heart valve ring used in repairs is not the only risk for thromboembolism. There are additional thromboembolic risks. And the most common of these likely to be encountered in clinical practice are atrial fibrillation and a left ventricular ejection fraction lower than 35%. It is common to encounter patients who have atrial fibrillation and patients who have systolic left ventricular dysfunction. In addition, a very important risk factor is history of previous thromboembolic events. Add to that older age and hypercoagulable states. Mechanical heart valves are constantly being developed and refined, and there are some newer generation pyrolytic carbon aortic heart valves which have been approved by the US Food and Drug Administration for a reduced target INR of between 1.5 to 2. But remember, these valves are not commonly used, and this valve, this recommendation is only for the improved valve in the aortic position. Now, let's come to the recommendations for the strategy for anticoagulating for prosthetic heart valves. Now, anticoagulation for prosthetic heart valves is best undertaken with vitamin K antagonists. And the choice is between warfarin and acinocumarol. In addition, we have heparin, we have low molecular weight heparin, we have aspirin and antiplatelet agents, but these are only adjuncts to vitamin K antagonists. So the mainstay of anticoagulation for prosthetic heart valves is warfarin. How do you test if the patient is adequately anticoagulated? The test done to judge the adequacy of anticoagulation is prothrombin time. On the basis of the prothrombin time, the international normalized ratio is calculated, and there are specific recommendations for international normalized ratio for each valve and for each situation. So what are the INR recommendations for prosthetic valves in the aortic position? With a mechanical aortic valve, vitamin K antagonist therapy targets an INR of 2.5. The range is 2 to 3, but an effort should be made to keep it as close to 2.5 as possible. Now, if this patient is in sinus rhythm, has low risk of bleeding, aspirin in a low dose between 50 and 100 milligram per day should be added to vitamin K antagonist anticoagulation. And as we shall see, there is benefit in adding aspirin to oral anticoagulation. Now, there are special circumstances in which we target a higher INR for prosthetic valves in the aortic position. If additional risk factors are present with an aortic valve replacement with a mechanical valve, and we've looked at those factors, most commonly atrial fibrillation and LV dysfunction, then a INR of 3 should be targeted, and the range would be from 2.5 to 3.5. We should also look at the kind of valve that has been implanted. Now, these valves are becoming less and less frequent in clinical practice, but you just might see some of the older generation valves in clinical practice. And when you see a Star Edward valve, which is a ball and cage valve, which shows up very well on the chest X-ray, or a tilting disc valve, a single disc valve other than Medtronic Hall, even if there are no other risk factors, the target INR should be 3. So these are the ACCP recommendations for antithrombotic therapy in patients with mechanical heart valve in the mitral position. When there's a mechanical heart valve in the mitral position, the target INR is 3 and the range is 2.5 to 3.5. Ditto with double valves. With mechanical heart valves in both aortic and mitral position, we treat as we would for an isolated mechanical mitral heart valve, and the target INR is 3 and the range is 2.5 to 3.5. And of course, one should add antiplatelet therapy whenever possible, whenever it is not contraindicated. So why do we add antiplatelet agents to oral anticoagulants? Studies have shown that the addition of aspirin to vitamin K antagonist therapy in patients with mechanical heart valves leads to a reduction in risk of thromboembolism and mortality when compared to VKA therapy alone, which means if you treat only with oral anticoagulants, treat only with warfarin, compared to that, if you treat with warfarin and aspirin, the outcome is better. So the addition of at least 50 to 100 milligram per day of aspirin is recommended in the current American College of Cardiology and American Heart Association guidelines for all patients with mechanical heart valves. However, there's a caveat. You must look at the individual's bleeding risk because aspirin is associated with significant bleeding. So if there are any risk factors for bleeding, then caution should be exercised before prescribing aspirin. Now, there are many newer oral anticoagulants. Most of them are factor 10A antagonists. Examples are dabigatran, rivaroxaban, fondaparinux, etc. Now, so the question arises whether these agents can be used to anticoagulate for mechanical heart valves. The short answer to that question is no. And the reason is investigators in the dabigatran versus warfarin trial, the realigned trial, randomized patients who had undergone aortic or mitral valve replacement to dabigatran dosed by renal function and warfarin to target the recommended INR. The trial had to be terminated prematurely because of an excess of both thromboembolic and bleeding events in the dabigatran group. So direct oral anticoagulants or the newer oral anticoagulants cannot be used when a mechanical heart valve has been implanted. Do bioprosthetic valves are much like the natural valve. Do bioprosthetic valves need to be anticoagulated? Bioprosthetic valves do confer an increased risk for thromboembolic complications during the first 3 months after surgery. And this is possibly because the sewing ring and the suture material implanted take 3 to 6 months to become completely endothelialized. And for that period of time, it is prudent to anticoagulate. Now, the risk associated with bioprosthetic valves is much lower than that associated with mechanical valves. So the target INRs are lower. So VKA therapy targets an INR of 2.5, a range of 2 to 3 for all bioprosthetic valves, irrespective of their position and type. To this should be added aspirin, again, if extra bleeding risk is not present, and aspirin should be continued after the first 3 or 6 months when oral anticoagulation is stopped. Do we need to anticoagulate for transcatheter aortic valve replacement? Present consensus is aspirin 50 to 100 milligram per day plus clopidogrel 75 milligram per day should be given for the first 3 months. Now, again, we come back to the question of newer oral anticoagulants. They cannot be used for mechanical valves, but can they be used for bioprosthetic valves? There's a growing body of literature suggesting better outcomes with NOACs in head-to-head trials against warfarin for non-valvular atrial fibrillation. Does a patient with a bioprosthetic valve implant qualify as non-valvular atrial fibrillation? Well, the answer to that question is not yet known. Whether the NOACs are safe and efficacious in patients in sinus rhythm early following the placement of a bioprosthetic valve remains to be answered. Every now and then, a patient who has had a mechanical heart valve or some other valve implanted will require surgery for some other reason. So what should be the anticoagulation strategy in these patients who need to undergo non-cardiac surgery and have a mechanical valve implant? Some kind of bridging strategy is required. Now, studies evaluating bridging strategies have found that major bleeding occurs more frequently than thromboembolic events. However, it is considered that major bleeding may be an acceptable complication to avoid thromboembolism, which may more significantly affect patients' long-term outcomes. So the strategy should be to avoid thromboembolism and bleeding both, but if a choice has to be made, one should err a little towards bleeding rather than towards thromboembolism. What are the guidelines for bridging for non-cardiac surgery in patients with mechanical heart valves? The American Heart Association and American College of Cardiology say that warfarin can be continued without interruption in a patient undergoing a minor procedure. So if the procedure is minor, there's no need to stop warfarin. In fact, we do operate on patients who are anticoagulate in emergency situations. And in many times, there is the bleeding is not so excessive that it cannot be taken care of.
3 minutes left, sir.
Am I running out of time?
3 minutes.
Okay. So for major procedures, warfarin can be interrupted for 3 to 4 days preoperatively without bridging in patients with low thromboembolic risk. Now, who is low thromboembolic risk? It is an aortic mechanical heart valve in sinus rhythm with no other thromboembolic risks. All other patients need to be bridged. So how do we bridge in a patient who has a mechanical mitral valve and needs to undergo major surgery? First step, hold warfarin 4 days before surgery. Then do daily PT-INR until the INR drops below 2.5. Now, as soon as the INR drops below 2.5, bridge with low molecular weight heparin. But if the patient has CKD stage 4 or 5, bridge with heparin. Surgery should be undertaken when the INR is less than 1.5. Stop the low molecular weight heparin 12 hours before surgery or the heparin 6 hours before surgery. 12 hours after surgery, the low molecular weight heparin can be restarted. Overlap with warfarin the next morning. Stop the low molecular weight heparin once the INR is more than 2.5. Discharge on the pre-op dose of warfarin and refer to the treating cardiologist. Now we have the complicated issue of pregnancy in patients with prosthetic heart valves. Patients with mechanical heart valves require lifelong anticoagulation. The risk of thromboembolic complications is increased during pregnancy because pregnancy is a hypercoagulable state. Warfarin crosses the placenta, heparin and low molecular weight heparin do not. So what are the options available? Oral anticoagulants throughout pregnancy, low molecular weight heparin in the first trimester, low molecular weight or heparin throughout pregnancy. Now, what happens if we give VKAs or vitamin K antagonists throughout pregnancy? The maternal mortality is the lowest if oral anticoagulation is continued throughout pregnancy. However, the downside is live births also are the lowest. So for women taking vitamin K antagonists throughout pregnancy, there is a risk of anticoagulant-related fetal and neonatal adverse events. What about heparin? The maternal risk of heparin use includes hemorrhage, osteoporosis, heparin-induced thrombocytopenia, and thromboembolic complications. Heparin does not provide as much protection as vitamin K antagonists do. The risk of thromboembolic events during pregnancy in patients treated with heparin is approximately 10% compared to 3.9 with oral anticoagulants. So what's a compromise strategy? There's no perfect strategy, but this would be a suggestion. Preconception on warfarin, low molecular weight heparin to minimize embryopathy in the first trimester, and return to vitamin K antagonists in the second and the third trimester, and unfractionated heparin at 36 weeks. What can be the risks and complications? There's a risk of fetal intracranial hemorrhage during labor because of the anticoagulated fetus. Now, if one has to undertake cesarean section, In a patient who's anticoagulated with vitamin K antagonists, it should be a cesarean section. It should not be normal labor, because normal labor can induce intracranial hemorrhage. Now, fetal anticoagulation behaves unpredictably and has no relationship with maternal anticoagulation. It takes much longer to settle down to a normal coagulation profile. Pregnant women who have well-functioning bioprosthetic heart valves have excellent pregnancies. They have uncomplicated pregnancies. But what is the problem with a bioprosthetic valve? A bioprosthetic valve undergoes structural degeneration. So if a patient has a bioprosthetic valve implanted at age 20, about 50% chance of re-surgery and change of valve in 10 years exists. So about 50% women of childbearing age will require valve replacement owing to structural valve disease 10 years after the original operation. And the thing to remember is pregnancy might accelerate structural valve degeneration. Now, the final condition that may be commonly encountered with prosthetic heart valve is endocarditis. Amongst the high-risk patient groups who can have endocarditis are patients with prosthetic cardiac valve. They are right there on top of the list. Now, it is estimated that a person with a prosthetic heart valve has a 50% greater chance of developing infective endocarditis than the general population. And this risk is highest between the first 6 to 12 months. The mortality of prosthetic valve endocarditis is 44%. It is a whopping 44%. Most investigators think that it is prudent to use prophylactic antibiotics in this select subset of patients. Now, how do we choose antibiotics? The choice of antibiotics depends on many things. In early prosthetic valve endocarditis, Staphylococcus epidermidis is the most frequent organism. The majority of late valve endocarditis is caused by Streptococcus viridans and Staphylococcus aureus. So we need antibiotic prophylaxis for invasive dental procedure, surgery at an anatomical site that is actively infected, and here we may be guided by culture reports. And if major surgery is planned, a prophylactic antibiotic will be administered anyway. So what are the choices? Amoxicillin for dental procedures, a cephalosporin if there's mild penicillin allergy, if there's Staphylococcus aureus suspected, clindamycin or clarithromycin, if there's MRSA, vancomycin. The antibiotic should be given in the following time frame: orally 1 hour before the procedure, intramuscularly 30 minutes before the procedure, and intravenously immediately before the procedure, so as to have highest blood concentrations at the time the incision is made. So in conclusion, I would like to say prosthetic heart valves increase life expectancy and greatly improve the quality of life. However, many aspects of prosthetic valves require fine management. Familiarity with anticoagulation and anti-infective strategies will lead to better management of these patients. Whenever in serious doubt, refer to a cardiologist. Thank you very much. Thank you for a patient here.
This lecture covered by Dr. Sushant. Dr. Sushant, General Practitioner, would like to know any particular suggestion after the valve surgery or as far as food is concerned to be taken by the patient?
Generally, if it's only heart valve disease, the only restrictions are on green leafy vegetables and green tomatoes, because they can increase the level of vitamin K and act counter to vitamin K antagonists. So the anticoagulation becomes unpredictable. So for most valve patients, that is the precaution we advise. If there's coexisting coronary artery disease, of course, the diet recommended for coronary artery disease or for diabetes is recommended with these precautions.
No need any question for the general audience, for the general practitioner regarding.
So I think with the time frame given to Dr. Sushant, I think it was a very, very crisp presentation. There are a lot of things to talk about heart valve surgery, but I think he focused on the management post-surgery, and I think that was a good idea, because a lot of non-cardiologists are handling valve cases, even post-surgery cases. So I think this is a very, very crisp and nice presentation.
Most of these patients, after having valve surgery in a specialist center, go back to their native place. And,
yeah.
They need to be managed by their physicians.
Physicians, yeah.
Familiarity with how to do it is important.
Yeah, I think it was a very nice presentation. Thank you, Dr. Sushant. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir. Thank you for your very insightful talk. And now it's time to move towards our next session. And for this, I would like to call upon Dr. Alok Gupta, sir, and Dr. Raj Kishore Singh, sir, as a chairperson, and Dr. Varish Nagar, sir, as a keynote speaker. For Dr. Varish Nagar, sir, if you ask me to describe him, it will be perfection. He's perfect to the core. His clarity in the subject has been guiding, and he's going to speak on which drug to prescribe after metformin, DPP-4 inhibitors versus SGLT2 inhibitors. So first, I would like to take an opportunity to introduce our chairpersons for the session. डॉक्टर आलोक गुप्ता सर के लिए मैं एक बात कहना चाहूंगा कि सरलता, सज्जनता और विद्वता की प्रतिमूर्ति हैं. He's a noble man with the character of great height and prophecy of distinctiveness, and originator of multiparous notion, a statue of knowledge and experience. And he's a fellow of UPDA. He's a fellow Indian Society of Hypertension, and he's a past he was the past president of RSSDI UP chapter and faculty of PHFI. He's presently also advisor of Diabetes Self-Care Association in Gorakhpur, and he's almost practicing for more than 20 years in the Gorakhpur, and is well known and possesses high quality knowledge and skill. So our next chairperson is Dr. Raj Kishore Singh, sir. He's devoted a great contribution in the field of medicine. Sir is illustrious educationist and known for his versatile experience of over more than 20 years in the field of education. And so with this, I would rather request Dr. Alok Gupta, sir, to please introduce our speakers for the session. Dr. Varish Nagar, sir.
Thank you, Dr. Prakash, for this very wonderful session going on.
Yeah.
And Dr. Varish from Devariya, he also needs no introduction. He is well known to all of us. You can call him a very good clinician or a very good academician or a mixture of two in one. So today he will be, and he's a very good quiz master. In all our conferences on diabetes, he is given the responsibility to make quizzes, and he's a very good quiz master. So today he will be quizzing with the fact that what comes after metformin. Should it be DPP-4 inhibitor? Should it be SGLT2 inhibitor? Lot of new data are coming up, but it is not that easy an answer to give, that a panacea answer for each and every patient. So he will better guide us how to tackle with this dilemma and in which patient to use which drug. To you, Dr. Varish.
Is my screen visible?
Yes, sir.
Yeah.
Okay. Thank you, chairpersons, and thank you, IMA Gorakhpur, Dr. PC Shahi, Dr. VN Agrarwal, and Dr. Shiv Shankar Shahi for giving me this opportunity to be with you, with all of you, and share my thoughts on what to choose after metformin. The target audience for this presentation is mainly GPs, and therefore I have simplified some concepts to make it usable for most of us. DPP-4 inhibitors, which include sitagliptin, linagliptin, vildagliptin, and teneligliptin, have some points in common. They have modest efficacy, but Indians respond better if HbA1c reduction in Caucasians is 0.7%, in Indians, the reduction is 0.9%. So we respond better. Compliance is very good. There is no hypoglycemia risk at all. Therefore, they are safe for pilots, scuba divers, and heavy machinery operators. They are weight neutral, and therefore they are suited for those patients where we do not want weight reduction. And some of the time, the patient to whom we are labeling as type 2 diabetes is actually not of type 2 diabetes. In those situations, also DPP-4 inhibitors have a place. They are renal safe, yes, but some dose modification has to be done. But in general, they are renal safe. Atherosclerotic cardiovascular disease wise, they are neutral. And CHF wise, they are neutral. But saxagliptin here is an exception because saxagliptin increases the chances of hospitalization due to heart failure. They are hepatic safe also and have no effect on fluid balance and electrolytes. Therefore, they are suited for elderly. They are safe in patients with autonomic neuropathy because they do not worsen postural hypotension. They do not cause fluid loss or electrolyte imbalance. So are safe there also. On the other hand, the key points about SGLT2 inhibitors, which includes empagliflozin, dapagliflozin, canagliflozin, and remogliflozin, are as follows. They also have a more modest efficacy, and Indians here also respond better than Caucasians. Compliance is good. Most of them are used in OD dosages except Remo. Here also there is no hypoglycemia risk and there is weight benefit. So the patient loses on an average 1.5 to 2 kgs of weight when kept on these drugs. So we know type 2 diabetic patients are usually overweight. So this is an added advantage. They have renal benefit. That is, they decrease proteinuria, they decrease the progression of renal disease, and they decrease the chances of patient landing into ESRD. ASCVD wise also, atherosclerotic cardiovascular disease wise also, they are beneficial, whereas SGLT DPP-4 inhibitors were neutral. CHF wise, again, they are beneficial. So much so that they are included in the guidelines for management of heart failure. Hepatic benefit, they help in NASH, non-alcoholic steatohepatitis, is benefited by SGLT2 inhibitors, but there is a possible effect on fluid balance and electrolytes. They can worsen dehydration and may cause electrolyte imbalance, and therefore they are unsafe in frail elderly people, especially those with postural hypotension and autonomic neuropathy. So this was in general. Now we will compare both of these classes head on. First, efficacy. Efficacy wise, both are equal. They decrease A1C by 0.7% approx. Indians respond better. Hypoglycemia wise, both the classes do not cause hypoglycemia. However, if there is hypoglycemia unawareness, meaning thereby that autonomic neuropathy is present, then we will not use SGLT2 inhibitors without measuring the line standing BP. And if there is postural hypotension, we will never use SGLT2 inhibitors. This we should always keep in mind. DPP-4 inhibitors have an added advantage. And what is the advantage? That if hypoglycemia happens, then hypoglycemia, these drugs help in preventing hypoglycemias. DPP-4 inhibitors help in preventing hypoglycemias by GIP-mediated stimulation of glucagon release. And this gives an edge when we are looking for patients who are pilots, scuba drivers, or heavy machinery operators or drivers. This gives an edge there. Effect on body weight, DPP-4 inhibitors are weight neutral, whereas SGLT2 inhibitors, they decrease the body weight by 1.5 to 2 kgs. Therefore, SGLT2 inhibitors are preferred if weight loss is needed. And in most of the type 2 patients, we need some weight loss. And in Indians, we need even more weight loss because we are more predisposed to atherosclerotic cardiovascular disease and insulin resistance. Renal benefit. DPP-4 inhibitors are very safe in renal disease. Some DPP-4 inhibitors require dose modification, but linagliptin and teneligliptin do not require dose modification in renal disease. Sitagliptin and Vilda, they need dose modification on the basis of eGFR, which is calculated by, there are many calculators available on the net or on your mobile app, from which you feed the creatinine value, the age, the sex, and you can get the eGFR value. Linagliptin has an advantage of decreasing proteinuria also, but overall it has neutral effect. So more or less DPP-4 inhibitors are neutral as far as renal benefit is concerned. On the other hand, SGLT2 inhibitors are renoprotective. They improve eGFR, they retard the doubling of serum creatinine, they decrease the chances of the patient landing into end-stage renal disease, they improve decrease proteinuria. The only caveat is that they don't decrease glucose, they don't work like an anti-hyperglycemic if eGFR is less than 30 ml. So if the eGFR is less than 30 ml per meter square per minute, then we should not use. But in future, they will be used in this situation also, but as on date, the guidelines don't recommend. Now, atherosclerotic cardiovascular disease reduction. This is very important because atherosclerosis is going on in every one of us, and the key factor in aging is atherosclerosis. If somehow we can find medicines which retard atherosclerosis, that will be a panacea. So DPP-4 inhibitors, sitagliptin and linagliptin are neutral as far as atherosclerotic cardiovascular disease is concerned. They are neutral on 3-point MACE. And what is 3-point MACE? 3-point MACE is non-fatal MI, non-fatal stroke, and cardiovascular death. Saxagliptin is also neutral as far as atherosclerotic cardiovascular disease is concerned, but increases the chances of hospitalization for heart failure. Therefore, we shall not be using it. Teneli and vildagliptin, we don't have solid data to tell that whether they will be beneficial or not. We don't have data. SGLT2 inhibitors, canagliptin and empagliflozin, they decrease 3-point MACE. This is important. And empagliflozin also decreases the cardiovascular mortality. So the only drug amongst these two, in the entire these two group, EMPA is the only drug which decreases cardiovascular mortality also. Dapagliflozin is neutral. Now, heart failure. All SGLT2 inhibitors are beneficial in heart failure. They are used not only in diabetic heart failures, they are also used in non-diabetic heart failures. And they are so effective that they have secured a place in guidelines. DPP-4 inhibitors, on the other hand, Sita and Lina are neutral on heart failure. Saxagliptin versus heart failure, and Teneli and Vilda, we do not know. So as far as heart failure is concerned, SGLT2 inhibitors are supreme. Hepatic safety. Both the classes are safe in mild to moderate liver disease. SGLT2 inhibitors are beneficial in non-alcoholic fatty liver disease. Vilda should not be used if SGPT is more than 3-4 times upper limit of normal. Amongst the DPP-4 inhibitors, linagliptin is the safest. Linagliptin is the safest when many comorbidities are present. You can use it in renally impaired, you can use it in hepatic impaired. So it's a versatile drug in that regard. Fluid and electrolyte balance. SGLT2 inhibitors, we have to be cautious if the patient is predisposed to fluid and electrolyte balance. If the patient is on diuretics, we have to be very cautious. And we have to be doubly cautious if the heart failure patient on whom we are using SGLT2 inhibitors is also on diuretics. There we have to be doubly cautious. If it's hot tropical climate, then also we have to be very careful while using SGLT2 inhibitors. They may worsen the postural hypotension in predisposed. DPP4 inhibitors, on the other hand, do not cause any fluid or electrolyte imbalance. Safety in elderly, DPP4 inhibitors are great. See, when you write DPP4 inhibitors, no one is going to question you that why have you written this drug? They are so safe. With SGLT2 inhibitors, we need to be cautious. And in elderly, we have to be even more cautious. And if he is a frail elderly, then we have to be even more cautious. Now, genitourinary effect. We know SGLT2 inhibitors predispose to genital fungal infections and can worsen UTI. In patients who have had pyelonephritis, we should avoid SGLT2 inhibitors. DPP4 inhibitors, they do not cause genitourinary infections. And a great point is that if we use SGLT2 inhibitors along with DPP4 inhibitors, then the chances of genital fungal infection decreases. So these two can be used together also. For fractures, CANA has a black box warning that it may predispose the patient to fracture, and SGLT2 inhibitors can cause euglycemic ketoacidosis also. Now, which one to choose? Which one is the best choice? Which one is the second choice? So we have to judge and decide. We will use SGLT2 inhibitors in young, overweight, type 2 patients. If the patient has a family history of diabetic kidney disease, then for sure we will keep the patient on SGLT2 inhibitor. If the patient has high CV risk, has a family history of premature coronary artery disease, if the patient is a smoker or has dyslipidemia, visceral adiposity, there we will use SGLT2 inhibitors. If there is heart failure or if echocardiography is showing diastolic dysfunction only, significant diastolic dysfunction, which can be studied by tissue Doppler E by E prime ratio being more than 16, there also SGLT2 inhibitors have a place, a good place, and NASH also, they are beneficial in NASH. When will we avoid SGLT2 inhibitors? We will avoid them in frail and elderly. If the patient has postural hypotension, if there are chances of fracture, we will avoid CANA. And in insulinopenic state, that if the patient is underweight or the patient is losing weight, then we have to be cautious, very cautious in using SGLT2 inhibitors. And we should be absolutely sure that the patient has only type 2 diabetes and not other type of like LADA. We should exclude LADA. So that can be judged by the body weight. So the patient in low body weight patients, we should never use SGLT2 inhibitors.
Sir, time 2 minutes. Sir, time.
Okay. DPP4 inhibitors, we will choose if we don't want hypoglycemia, if the weight is near target, and we don't want further weight reduction. In pilots, scuba divers, heavy machinery operators, if eGFR is less than 30, then SGLT2 inhibitors will not work, and there LINA is a good choice with insulin. If the patient is predisposed to electrolyte imbalance, like on diuretics or the patient living in tropical climate, there we will choose DPP4 inhibitors. Frail and elderly and patients with postural hypotension, we will choose DPP4 inhibitors. Avoid, so there is almost no place where DPP4 inhibitors cannot be used. Even in heart failure, sitagliptin and linagliptin can be used. But one thing, what I feel, that if the patient has a refractory heart failure, then we should avoid using these this group of drugs. And here it's these are the guidelines which are clearly showing that DPP-4 inhibitors, they are safe in so many ways, be it weight, be it renal, genitourinary, and so DPP-4 inhibitors are very versatile. You can use it right and left, and no one is going to question you. And yes, why can't we use both of these drugs together? We can use and we should use. So if the target A1C, suppose we want 2% A1C reduction. So 0.9 we will get from DPP-4 inhibitor and 0.9 we will get by SGLT2 inhibitors. So we can combine both of these two and use them. Thank you.
Thanks a lot, sir, for such a wonderful, crisp, and very warming presentation.
Hello, Raj.
And really, it's wonderful, and really, it will work as a lamp for all of us in deciding where we have to choose SGLT2 and where we can use both. Any questions from audience?
Omkar is here.
Only
yes,
praising words in chat box for you, sir. And this is the magic of your wonderful presentation. There is no question.
I've got a compliment. Varesh has used a beautiful background from Varanasi, I believe, or from Ayodhya.
Yes.
Yes, sir. Yes, sir. It's very wonderful presentation, and background is looking very good.
We are Indians. We have to be proud of that.
Sir, really, sir, your presentation is very crisp.
It's Varanasi.
And very to the point.
Thank you.
Dr. Rajkishore, sir, if you want to add something to it.
Yes, Raj.
There is nothing to add. We can only underline. We can use both. If we have to use one, always prefer, in most of the situation, we have to prefer SGLT2 as per Varesh, sir. There is nothing to add.
Okay.
Sir, masters के master.
अरे छोड़ो यार. छोड़ो.
शानदार सर, शानदार एकदम.
ओएन का कुछ सवाल होगा?
नहीं सर.
ओएन जो है यूग्लाइसेमिक कीटोएसिडोसिस.
नहीं सर, यूग्लाइसेमिक कीटोएसिडोसिस पे कोई क्वेश्चन नहीं है. बस ये है कि इतना क्लियर था कि हम स्लाइड देख रहे थे, हमने कहा इसके बाद तो क्वेश्चन बनेंगे ही नहीं.
बनेगा ही नहीं.
ऐसे सारे क्वेश्चन.
There is only compliments in chat box.
शानदार.
There is only compliments. There is no question at all.
Okay. We'll take the questions at the end of this CME with the audience interaction. So I think it's time to move to our next session. Thank you, Varesh sir, for your excellent talk. And for this next session,
लॉबी छोड़ के उधर से खाना आ गया.
Call upon Dr. Shailendra Kumar sir and Dr. Onkar Rai as the chairperson and Dr. Dharma Chaudhary sir as a keynote speaker, and he's going to talk on refractory anemia and basics of bone marrow transplant. And first, I would like to introduce our chairpersons, Dr. Shailendra Kumar sir. Dr. Shailendra Kumar sir is a very senior physician who has been in practice of medicine since 1986. His logical and holistic approach to management of various lifestyle-related diseases like high blood pressure, diabetes, cardiac and vascular diseases is rewarding and is logically giving the way forward in day-to-day practice medicine. He is MBBS from BRD Medical College, Gorakhpur, and he did his MD from AIIMS BHU Varanasi in 1983. And he recently did his CCE BDM course from PHFI in 2020. He's having experience in serving UPPMS, and he's presently attached to State Bank of India as a senior bank medical officer. And he's presently holding the post of President GP Association Gorakhpur, Member Association of Physician Gorakhpur Chapter. He's member Indian Medical Association Gorakhpur and member of RSSGI. And our next chairperson for this session is Dr. Onkar Rai. Next. Dr. Onkar is a very renowned physician. Hello. From Gorakhpur.
Slide is not there of Omkar.
Just a minute, sir. It's stopped. Just a second.
Okay, not a problem. So Omkar is a very renowned physician from Gorakhpur. His MBBS from Jaiswal Medical College and did his MD from BRD Medical College, and he's practicing for last 15 years. And he's published many articles, and he's a very good orator, and he's having a very good participation in all the conferences being held in Gorakhpur. So with this, I'd like to invite Dr. Shailendra Kumar sir to please introduce our next speaker, Dr. Dharma Chaudhary sir. Please.
Very warm welcome to all the intellectual members who are present in this webinar. This is my proud privilege to introduce Dr. Dharma Chaudhary, an erudite medical scholar who is going to enlighten us on the topic of refractive anemia and the basics of the bone marrow transplantation. We all know that the refractive anemia is usually missed through serious condition, and the only ray of hope of complete treatment lies in bone transplant and stem cell transplant. And Dr. Dharma Chaudhary is doing it in a very fine way at PLX Max Center of the Bone Marrow Transplant. Dr. Dharma Chaudhary is one of the most prominent bone marrow transplant physicians in the country with a proven experience of conducting life-saving transplant procedures. He is instrumental in the inception of the BLK Center of Bone Marrow Transplant, which is a 24-bedded dedicated center. Owing to Dr. Chaudhary's immense contribution, the center is now reckoned amongst one of the largest centers in the Asia. He has done his MBBS in MD medicine, along with super specialization in DM clinical hematology from All India Institute of Medical Sciences. He has got his fellowship from eminent institutions of our country, Christian Medical College, Bangalore, NSC PGI, Lucknow. He has also gained the experience and knowledge from abroad by having his fellowship from Vancouver General Hospital, BC Cancer Agency, Vancouver, British Columbia, Canada. Regarding his clinical experience, hematology and hemato-oncology are his interests, along with hemoglobinopathy transplant in thalassemia and sickle cell, bone marrow failure syndrome, aplastic anemia, Fanconi anemia, haploidentical transplant, graft versus host disease. Dr. Chaudhary and his team has carried out more than 1,100 bone marrow transplants independently, majority of which was in thalassemia major patients or patients diagnosed with acute leukemia, myeloid and lymphoid, aplastic anemia, multiple myelomas and lymphoma. We routinely perform transplant on both pediatric and adult patients. With his immense contribution, the BLK Max Center of the Bone Marrow Transplant is now reckoned as the largest center in the Asia, catering not only patients from India, but from abroad, namely Pakistan, Afghanistan, and several other countries from Middle East and Africa. The topic is so vast. I will not intervene and request Dr. Dharma to enlighten us on this topic. Over to Dr. Dharma.
Thank you, Dr. Selen, for your kind introduction, and I'll thanks the IMA team of Gorakhpur for invitation. And what I will do over the next 15 minutes, 15 minutes, to give you the brief, what is, refractory anemia. And I think for physician, we need to understand majority of time the patient comes, this is a common anemia, which is not properly evaluated. And at the end, probably I'll give the basic of the transplant, because that is the field where most of the people are moving to cure incurable diseases. So, my slide is visible?
Yes. It is visible, you can continue.
Yeah. Just one second. So anemia, the definition is like there's a decrease in hemoglobin or red cell. And this is almost always a secondary disorder. This is not a primary disease itself. It's the most common hematological disorder. And as an internist, we should all know how to evaluate and determine the cause. So recognition is the key, and the diagnosis is usually like on the Yeah. History and evaluating sign and diagnosis. Do not overlook the primary problem, because primary problem is the culprit for patient. And the basic workup should be the routine hematological, biochemical, along with the vitamins assay and iron studies. One should always consider LDH, and when you little extended workup, one should always consider if there is a LFT derange, do haptoglobulin Coombs test, and hemoglobin HPLC is very common because majority of the hemoglobinopathy is undiagnosed, thalassemia minor. And if you are suspecting anywhere the hemolysis, hemoglobinuria, PNH, followed by osmotic fragility, or wherever they indicated, the one has to consult GI consult, because every anemia, IDA, and is refractory and is GI malignancy is there. So one should consider GI consult, and the hematologists come on the picture when the marrow is at culprit. So this is the basic approach. Just a second. Yeah. So when you have low hemoglobin, how to move? Because this audience is general physician and GP. So whenever you have low hemoglobin, one can look at, is the only red cell is affected, or you have abnormality in the other cell line. So wherever there's the abnormality line, then more than one cell, you always consider the marrow is at culprit. When only the red cell is at culprit, you should do retic count. If the range, this is basically a blood loss or hemolytic anemia, or if reticulocyte count is suppressed, it's not raised appropriate to degree of anemia, then always look at the red cell indices, microcytic, macrocytic, or normochromic. And always the key to diagnosis, if one physician can look at the hemogram properly, he can diagnose almost 80 to 90% of anemia. So MCV less than 80, microcytic, look at iron studies, which will tell you whether there is iron deficiency anemia or anemia of chronic disease or hemoglobinopathy. So microcytic, very simple to diagnose, and one should not confuse with any fancy diagnosis. Only 3 diagnoses for microcytic hypochromic anemia. Go to macrocytic anemia, where MCV is more than 100. You look at the PS report. If there is a megaloblast and segmented neutrophil, they present either B12 folate deficiency, and if it's not megaloblastic, then the diagnosis will come myelodysplastic syndrome, liver disease, or marrow failure syndrome. Wherever the problem comes, majority of time when you have normocytic normochromic anemia. So the retic count helps whether it's hypoproliferative or hyperproliferative anemia. Hyperproliferative is always hemolytic, or the stress secondary to the massive bleed, and hypoproliferative will be the marrow at culprit. So one has to look at whether it's leukemia, aplastic anemia, pure aplasia, or anything. Or clinically, you can define anemia either absolute or relative. So relative anemia, where increased plasma volume is commonly seen in pregnancy, or where you have macroglobulinemia. The absolute anemia, depending on the red cell production, you can classify. So blood loss anemia, whether increased red cell destruction or underproduction. So this is the flow diagram which tell you the physiologically, where either reticulocytopenic index is more than 2.5, so hemorrhage or hemolysis. When you have less than 2.5 reticulocyte index, either normocytic, hyperproliferative, or micro or macrocytic, where your maturation disorder are there. So microcytosis, as I said, very few example. And when you look at the common microcytic disorder, iron deficiency anemia, thalassemia, and this is the problem. The physician need to really look at whether this patient is not suffering from chronic disease. And any disease which persists for more than a week, even ICU stay, that can lead to chronic anemia. Normocytic anemia with normal reticulocyte count or reduced, the ACD should be think, and or bone marrow infiltration and MDS. So word about anemia of chronic disease, it's very common in the today's world, where people are having access to food, the deficiency disorder are less, and all the chronic diseases are there. It's very common, develop over 1 to 2 months, non-progressive, usually mild to moderate, but many patients do have the hematocrit gets less than 20, and the platelet white cell count, they may be normal or reactively they can increase. So when you look at anemia of chronic disease, what all you need? You need iron status, serum ferritin, and then you can decide what you're going to do with this patient. Iron deficiency anemia, when your serum ferritin is less than 30, when you have serum ferritin is little more than 30 to 100, your diagnosis will be different. So one has to follow the algorithm, and all the common tests are available across the country. And one can determine what is the problem. Before you call it's refractory, you need to exclude all the diseases. The patient who has a high retic count, as I already said, either blood loss or hemolytic anemia. So, and when you look at hemolytic anemia, always look at PS finding. Every pathologist from the small center to the higher center, they write, but many times we ignore the presence of spirocyte. Just tell you that you should look at the autoimmune process. If there's cystocyte, and then you should look at either the TTP, volular prostatic thrombosis, the breakdown or malignant hypertension, or even the chronic DIC and carcinomas. So if there is any abnormal cells are notified, one should give the importance to that. So never ignore any PS finding, because it's not written for out of the blue box. So when you have problem with the macrocytic anemia, always look at the blood smear or marrow. Megaloblastic, as I said, it's a deficiency disorder, but in non-megaloblastic, you need to look at either MDS and any other problem. And always consider if you have MCV of more than 110 or 15, it's a deficiency disorder. Nothing else can be there. So treat with the B12 and folate before even labeling the refractory anemia and other. So refractory anemia comes any of group of anemia condition that is not associated with another disease, and that is marked by persistent, frequently advanced anemia that can only be successfully treated through blood transfusion or transplant. So refractory is not only iron refractory, it has to be refractory to the B12, folate, and many other diseases before labeling this is refractory anemia. And always give the proper therapeutic trial of the iron, vitamin B12 and folate, even parentally, before calling it refractoriness. And the refractory anemia is typically, we call in the MDS syndrome. So refractory anemia is part of MDS. It's acquired pluripotent stem cell disorder leading to one or more peripheral blood cytopenia and dysplasia in the blood and marrow. So these are the classification depending on the number of the cell line dysplasia, number of the cell line affected, percentage of blast. So refractory anemia with ring sideroblast, multilesion dysplasia, and going toward the spectrum of the leukemia RAEB1 or RAB2. And in the new classification, unclassified dysplasia is also there. So wherever you're thinking is an unexplained thrombocytopenia, anemia, wherever refractory cytopenia, always look at the blood film subjected to the bone marrow examination. And in today's world, where you need to decide the treatment, so cytogenetics and molecular studies comes with the very important tool. So whenever you are doing marrow, you should send all the sample, because you cannot do marrow again and again. So how to diagnose MDS? The peripheral blood. So the pancytopenia, leukocytopenia, platelet count less than 100,000, hemoglobin less than 12, or reticulocyte count depending on. So and subject to the bone marrow, cytology will tell you the difference, dysplasia, cytogenic testing, and mutation analysis. So what is there? If there is asymptomatic cytopenia and this is MDS, you should wait and watch. Versus symptomatic cytopenia, where there is anemia or pancytopenia, you have to treat. And cytogenic sometimes can tell you even the simple deletion 5 abnormality, you can treat with the simple lenalidomide, and patient can respond very well. and giving erythropoietin therapy for anemia is keystone. And those who are high risk MDS will need the aggressive management, either in form of chemotherapy, the transfusion support, or hypomethylating agent, versus very fit patient can go for allo transplant, because these MDS, as I said, these are stem cell disorder, and the transplant is only cure. So MDS is a group of common malignant stem cell disease, mainly encountered in older people. So as our life expectancy is going up, you are looking more and more MDS and secondary leukemia. Diagnosis of MDS require blood and marrow and cytogenetic analysis. IPSS we follow for risk stratification and to decide the treatment. And treatment is mainly either supportive treatment or transplant. So just in this first half, what is the important point about anemia? You need to know how the response you document and when to response occur with the hematinurics. And anemia is just a finding, not a diagnosis. Always check the retic count first and then treat. And the final word, never examine the patient as whole and do not just change the number on the CBC. Look all aspects of CBC, including white cell count and platelet count. Many times this patient are focusing on 4 hemoglobin versus patient is having 70,000 platelet count, and when you subject marrow, this is leukemia. So always consider the whatever pathologist report and then move. And in next few minutes, I will give you just the brief gist of the transplant. What is transplant? What a physician should know. So marrow transplant is a medical procedure. This is no surgery, it's a medical treatment. And historically, what we used to say, you take the marrow from the donors, the PSIS, and push into recipient intravenously. So donor bone marrow cells repopulate into the recipient. And the current terminology is hematopoietic stem cell transplant. And the objective are basically for why we do transplant, to deliver high dose chemotherapy. So many of the tumors are chemosensitive, so they can overcome the lethal dose of chemotherapy. It's to provide a source of hematopoietic stem cell transplant to ablate the marrow. It stabilizes the organ graft tolerance to prevent rejection and provide immune effector cell to mediate graft versus tumor effect activity. So immunological, cure for these diseases. And the stem cell transplant can be depending on the source of stem cell. When historically, say bone marrow transplant is when you're collecting stem cell from marrow, peripheral blood stem cell transplant, or umbilical cord blood transplant, or depending on donor also, whether related or unrelated. Related can be full match, and today is the date, half match donor transplant are more and more carried out. A word about auto transplant. It's a misnomer term. It's a high dose chemotherapy basically, and the stem cell are used as a rescue. Advantage have very low TRM, transplant related mortality of less than 1%. There's no rejection, but disadvantage because it doesn't cure. There's no immunological benefit, no graft versus tumor effect, and there can be potential for tumor contamination. And the auto transplant, autologous stem cell is simply collected from the peripheral blood, like platelet apheresis, after giving growth factor, and the stem cell come from the marrow to the blood, and you can collect. And these stem cells are used after giving high dose chemotherapy. So what are the diseases you can cure or operationally cure with the auto transplant? In the current world, the multiple myeloma is the most prominent indication of transplant in the whole world, and it can effectively give good quality of life and long-term survival. Relapse non-Hodgkin and Hodgkin lymphoma, and many pediatric solid tumor. Coming to allo transplant, it's needed donor. So what we say, suitably HLA identical donor. There's advantage because it's provide cure because of graft versus tumor effect. There's donor immune response against malignant cell, but at the same time it have a high mortality because of graft versus host disease, infection, or graft rejection. And what you need a suitably HLA matched donor, typically on class 1 and class 2, either 6x6 antigen or 10 antigen matched donor. And chances of match, one sibling if you have, there's 25% chances of match, and the larger family size, you can have more chances of match, and you can find more chances of match where there's consanguineous marriages are happening. Yeah, this is the word that every person today you can go for transplant because half match donor is there, and you can do transplant on the unfit patient to fully fit patient, and the donor never lose anything, and you can cure patient with leukemia, MDS, chronic leukemia, or even non-cancer disorder like thalassemia and aplastic anemia. And aplastic anemia should be considered as a medical emergency. So every patient will go for a stem cell harvest, and we can use cryopreserved or fresh. And these patients will have different phase, like conditioning phase, the transplant phase, and the follow-up phase. Every patient will go for set of investigation, and these are the primary step. So every physician should know, because they should undergo for transplant sometime. So conditioning regime, they will get graft-versus-host disease prophylaxis, they will get stem cell reinfusion, wait for engraftment, monitoring. Infection is the biggest problem, so one should be very much aware about infection in transplant, and even post-transplant when they are immunologically incompetent. So graft-versus-host disease is a problem, but at the same time it brings the cure also, because those patients malignant disease where you have graft-versus-host disease, you can have minimum chances of relapse. If you do not develop the GVHD in leukemia, like twin transplant, maximum chance of relapse are much more. Every patient will go back to you for post-transplant vaccination, and transplant should be offered upfront, because once you relapse, your outcome is less than 5%. And early transplant is key in every possible diseases, like thalassemia, leukemia, or aplastic anemia. And if aplastic anemia is like acute MI, if you diagnose today, transfer the patient to the respective center, and you can get cure almost 90 to 100% of patient. So I will end here and take the question.
Hello. It's a very good presentation by Dr. Dharma Chaudhary. There's a lot of questions, so I am elaborating the question one by one, sir.
Yes, sir.
The first question is by Shahzad Mirza. Is a manual reti count is more reliable or automated?
So today's date, good, quality control automated counter is equally good. So you don't need any manual count. Manual counts are always biased. Automated are more better if you have good quality control of your lab.
So the second
from Dr. Varesh Nagarath.
Yeah.
I have just forwarded to you.
Yeah. The second question is Dr. Varesh, sir, to everyone. What are the CBC indices which prime to MDS?
So CBC, you look at either there is one cell line affected, red cell, or 3 cell line affected. So you can have monocytopenia, but the typically MCV will be in the range of 100 to 110. So you need to suspect above 110 will be megaloblastic anemia. So typically these are normocytic, slight macrocytic, the red cell.
Sir, another question is when we refer the patient of multiple myeloma, although multiple myeloma is very common disorder in after anemia and
absolutely, the myeloma can goes to physician, can go to orthopedician, the renal failure.
When we refer the patient of myeloma, although myeloma treatment of medical treatment of myeloma is very good, when we refer the patient of myeloma to BMT.
Absolutely. Ideally, every myeloma who is below 70, otherwise fit, they should get transplant, because that is cheapest possible available best treatment in this country or world. So once 3 to 4 cycle of any chemotherapy, the VRD or whatever induction chemotherapy, they achieve VGPR or CR, they should be referred to transplant, because 8 to 10 lakhs, any center in the country which is cheapest, like 1 month treatment of the daratumumab will be more expensive if they relapse. So every patient should be given chance for high dose chemotherapy, because that is long-term survival. 8 to 10 years you can get treatment-free survival.
As a whole, any contraindication, the list of contraindication of bone marrow transplantation as a whole, any disorder like MDS.
So we do not advocate transplant those who are having any other active malignancy, or you have active HIV infection, particularly allotransplant. or uncontrolled autoimmune disease. But autoimmune disease also, autologous transplant is coming upfront, like systemic sclerosis, multiple sclerosis, and even JRA. So there is no contraindication if the organ systems are okay. Myeloma, even we do transplant with renal failure. So the dictum is that you do marrow transplant. If your disease is controlled for 6 months, then these patients can be subjected for kidney transplant. So marrow transplant become more priority for myeloma.
Okay, sir. Dr. Selen, sir, over to you.
Unmute yourself, sir.
Unmute, sir.
Thank you, Dr. Dharma Chaudhary, for this elaborate presentation. We are really more richer in our knowledge regarding the anemia and the bone marrow transplantation. One question I want to know that when a case goes for bone marrow transplantation, what is the duration and what is the cost which he has to incur roughly?
So autologous transplant for myeloma and lymphoma, they used to stay in hospital for 21 to 25 days and cost around 8 to 10 lakhs. Allo transplant, it's all depending on whether you have match sibling donor, related donor, match unrelated donor, or haploidentical. Usual period between 4 to 6 weeks they stay in hospital, and the cost can be anywhere for match related is around 15 lakhs to haploidentical when goes to 20 to 25 lakhs. Unrelated, all depending on from the which part of the world we get the stem cell from the various registry. So it can goes between 30 to 60 lakhs, which will be 1/5 or 1/10 of the whatever is cost in the across the other part of the world.
What is the survival rate of post-transplant?
So survival rate is all depending on what disease, what stage of the disease you're doing transplant. Typically benign disease like aplastic anemia, as I said, if you diagnose today young aplastic, tomorrow you do transplant, the chances of long-term cure is more than 90%. Thalassemia, we have our own 250 transplant published data, more than 88% survival, 82% thalassemia-free survival. Leukemia is depending on if you're doing upfront, you're doing on the relapse, you're doing on the refractory. So, but overall, 60 to 70% can get cure even in this bad cohort patient.
Thank you. So nice of you, Dr. Dharma Chaudhary.
I'm sorry because this is vast topic and as we discussed before even the meeting. So anemia you can speak in the hours and hours, and transplant you can speak for days.
We will definitely invite you at Gorakhpur for physical meeting after Corona period.
Thank you so much.
That will be more informative for us. Thank you.
Dharma sir and chairpersons, it was really an insightful talk and sir ने बिल्कुल गागर में सागर really भर दिया. अब हम next session की तरफ move करते हैं, and for next session I would like to invite Dr. Gauranarayan Gupta and Dr. Dinesh Kumar Singh as a chairperson and myself as a keynote speaker. And I would like to introduce Dr. Gauranarayan Gupta's profile. So Dr. Gauranarayan Gupta is a renowned cardiologist from Gorakhpur, and he has changed the way we look at the intervention cardiology in Gorakhpur. He is MBBS from Manipal Academy of Higher Education, Karnataka. He did his MD from Parvara Institute of Medical Sciences, Maharashtra, and he did his DM cardiology from Dr. NTR University of Health Sciences, Andhra Pradesh. He's a fellow of American College of Cardiology. He's adjunct faculty to National Hypertension Working Group. He's a regional faculty for advanced course in management of diabetes and cardiovascular disorders of Public Health Foundation of India, regional faculty for certificate course in hypertension of Public Health Foundation of India. So welcome, Dr. Gaurav. Our next chairperson is Dr. Dinesh Kumar Singh. He's a very enthusiastic cardiologist in Gorakhpur. He joined recently, and he's changing the scenario of cardiology in Gorakhpur also. He's done his MBBS from North Bengal Medical College, Darjeeling. He did his MD in medicine from King George Medical University, Lucknow. He did his DM in cardiology from RML Institute of Medical Sciences, Lucknow. His previous experiences were he did his post-DM senior residency in interventional cardiology from RML, and he was a senior consultant in interventional cardiology in Shahi Global Hospital, Gorakhpur. and he presented his got his awards in best presentation in 2018 from UPCSI Lucknow. So with this, I'd like to ask Dr. Gaurav Gupta to proceed further for this session.
So I request Dr. Gaurav to read profile of Dr. Prakash Shai.
Good evening, everybody. It is my proud privilege and honor to introduce our next speaker, Dr. Prakash Shai, who is also the scientific secretary of AIIMS, and this is basically all what we are witnessing over the past 1.5 hours is his show. He did his MBBS from GSBM Medical College, Kanpur, MD Medicine from KGMC, Lucknow, and DM Cardiology from Ram Manohar Lohia Hospital, New Delhi. He has been senior consultant in interventional cardiology at Saroj Hospital, New Delhi, ASI Hospital, New Delhi, Bhagwati Hospital, New Delhi. He is a fellow of the European Society of Cardiology, fellow of American College of Cardiology. He was awarded the Colonel K.L. Chopra Award in 2013. I believe he's the only one in Eastern Uttar Pradesh to have received this particular honor. And he did receive Best Case Award in National Intervention Council meeting held in New Delhi in 2015. I invite Dr. Shai to please proceed further. Thank you.
Thank you, Dr. Gaurav. Thank you for your kind introduction. And let me share my slides. I hope it's visible.
Yes.
So I'll not take much of your time. It's already too late. So my topic is all ST elevation amide does not need thrombolysis or primary PCI. Basically, आप लोगों को कंफ्यूज नहीं करना चाहता हूँ, STEMI का ट्रीटमेंट थ्रोम्बोलिसिस ही है और प्राइमरी PCI ही है, और इसमें प्राइमरी PCI is the gold standard of treatment. So what I'm going to talk about is so basically, you have to know the differential diagnosis of ST elevation first on ECG. So there are basically 12 differential diagnoses, and to name them, the most common is ST segment elevation myocardial infarction for sure, and another most common is ventricular aneurysm. Other is pericarditis, and another very important entity which is most of the time misdiagnosed and underdiagnosed is Takotsubo cardiomyopathy. And another is benign early repolarization pattern. So how will you determine based on the ST elevation whether it's malignant or it's benign one? So on the right panel, you can see here that if you look at the ST elevation, if it's looking sad face, then it's a malignant one. It indicates in acute injury. But if it shows the smiley face, here you can see if it is showing the smiley face, then it's probably the benign one. So I will just run a movie clip here. You can see that just for 10 seconds.
मारेगा तू, मारेगा, मार, मार। प्यार में और जंग में सब कुछ जायज है। उसने प्यार किया है, जंग मैं छेड़ूंगा। भगवान का दिया चाहे सब कुछ बर्बाद हो जाए, उस अर्जुन से हारूंगा नहीं, टूट जाऊंगा, लेकिन झुकूंगा नहीं।
So आपने देखा कि यहाँ पे नाना पाटेकर कहते हैं कि टूट जाऊंगा पर झुकूंगा नहीं। तो यहाँ पे एक स्ट्रेसफुल सिचुएशन थी, और स्ट्रेसफुल सिचुएशन के बाद पेशेंट जो है उसमें पेशेंट को एक्यूट चेस्ट पेन हुआ। तो इसी स्ट्रेसफुल सिचुएशन की हम बात करेंगे। इसमें एक एंटिटी है जिसे हम ताकात्सुबो कार्डियोमायोपैथी कहते हैं। इट्स नोन विद मेनी सिनोनिम्स लाइक ब्रोकन हार्ट सिंड्रोम, स्ट्रेस इंड्यूस्ड कार्डियोमायोपैथी एज वेल, जिसका प्रेजेंटेशन बिल्कुल एक्यूट हार्ट अटैक की तरह होता है। एक्यूट चेस्ट पेन होगा, ईसीजी बिल्कुल एक्यूट मायोकार्डियल इंफार्क्शन की तरह लगेगी। देयर विल बी एसटी एलिवेशन, ट्रोपोनिन कराएंगे, बायोमार्कर्स कराएंगे, दे विल बी रेज्ड। Along with, if you look at the echo, there will be severe reduced ejection fraction, and unless you go for the angiogram, you will not diagnose this condition, because these patients are having the normal coronaries despite the similar features as with the acute myocardial infarction we see in day-to-day practice. So a little bit about history of Takotsubo cardiomyopathy. It was first described in 5 Japanese patients in 1990, and it took another 11 years to document it and report it in the JAC. So it was first reported in 2001, and since then a lot of data and is upsurging regarding this cardiomyopathy. as you know that it was named because of similarities between LV in systole. There is a, you can see here, there is a narrow neck with a wide base as with the shape of Japanese octopus trap. It is also called as apical ballooning syndrome, broken heart syndrome, and very commonly and contemporarily as stress cardiomyopathy. So there is no single test to diagnose this stress cardiomyopathy. So there is a group of conditions. You have to look at the patient's echo. There should be some regional wall motion abnormalities, which is not typically in single coronary distribution. Also in angiography, there should be no angiographic evidence of obstructive coronary disease or acute plaque rupture. If you look at the biomarkers, there should be some elevation or modest elevation in troponin in these patients, and you have to rule out probably some absence of leukocytoma or myocarditis. So if you look at the epidemiology, it was rarely reported before 2001, and probably it is because of it's most of the time it is underdiagnosed. We don't look at it. We just say that after angiography that it is the recanalized LED or recanalized LCX kind of things. Most of the time, we cardiologists also miss this condition, and the current estimate is around 2 to 3% or 1 to 2% in various reports. As you look in the Horizon MI acute MI study, it was reported exclusively in women's, never not in men's. So it is the condition which is very common in females, especially those who are in the range of age of 50 to 80 years, mostly post-menopausal, and 90% of cases involve women. So the most common precipitating factor for this condition is in 50% cases, it is emotional, or in 50% cases, it is physical stress. So the typical presentation, as I've already mentioned, that it is acute myocardial infarction. It is very similar to acute myocardial infarction. There will be chest pain, there will be dyspnea, and rarely there will be syncope. Also, these patients can present with cardiac arrest as well. The ECG is typically showing the ST elevation MI. There will be ST elevation on ECG, T inversion, even Q waves are documented. There will be elevated biomarkers, but the most important thing is to understand here that the peak of troponin, as we see with the ST elevation MI, is not that much. So there is a contradictory from echo finding and the rising biomarkers. So these are the ECG patterns of documented Takotsubo cardiomyopathy patient. Here you can see that there is ST elevation on the right panel, and these are the evolvements of STT changes as we see on day-to-day practice in patients with acute MI. So this is the classical presentation of Takotsubo cardiomyopathy. When you look at the echo of these patients, and if you see the basal segments are hypercontractile, and here you can observe that there is no single coronary artery distribution. The LED and L6 territories are hypokinetic. Whole of the apex, mid, and apical segments are akinetic segments. So whenever you see this, you have to suspect that it could be a case of Takotsubo cardiomyopathy. So if you look at the pattern of troponin elevation, this orange one is for the typical acute MI cases, and this blue one is for the Takotsubo cardiomyopathy. So here you can see that though the EF in Takotsubo cardiomyopathy is much lesser as compared to the acute MI, but the troponin rise is really modest. It doesn't reach up to that level of patient as in patients with ST elevation MI. So this is the one coronary angiogram after the Takotsubo cardiomyopathy. Here you can observe that this is the left main artery dividing into the LED and LCX, and these, when you subject these patients to coronary angiogram, it's absolutely normal. And this is why these patients should be diagnosed at earliest, because you can save these patients from early thrombolysis. With probably these patients can prone for the bleeding with the thrombolysis kind of things. So this is the angiogram, left ventriculogram. This is the gold standard for diagnosis of apical ballooning syndrome or Takotsubo cardiomyopathy, because here you can see a catheter is lying in the LV cavity, and after you give the dye, you can see this is the apex of the LV body, and this is the base of the LV body. And you can see clear cut over here that the base is hypercontractile and apex is not moving at all. So if you look at the burden of arrhythmias in Takotsubo cardiomyopathy, because it was earlier thought that once the angiogram is normal, these conditions are usually benign. It was earlier thought, but the data is upsurging that it is not a benign condition. It is equally malignant as acute myocardial infarction. If you look at the burden of arrhythmias, these patients are equally prone for atrial fibrillation, paroxysmal supraventricular tachycardia, as well as for ventricular tachycardia and cardiac arrest. So this is one data was being published in New England of Journal of Medicine, where they have shown what are the basic emotional and physical triggers which can lead to the Takotsubo cardiomyopathy. These are the emotional stressors which are really documented. If there is any close relative or friend's death, interpersonal conflict, job issues, financial issues, anger, lot of anger, frustration, any panic, diagnosis of malignancy, any bad news, or even public speaking is reported to cause these patients develop into the acute heart weakness, which is known as Takotsubo cardiomyopathy. And these are the physical stressors which is being documented in 50% of these patients, and these can be mainly longer duration of surgery, especially cholecystectomy, hysterectomy, or severe sepsis even can lead to acute heart weakness, thyrotoxicosis, seizure even can be documented. And here you can see that even the dobutamine stress echo is being reported to cause acute heart weakness. The patients can end up into the acute critical illness of Takotsubo cardiomyopathy. So this is one case report of being published where the jellyfish has bitten this patient, and patient developed the typical STT changes. But on angiogram, this was absolutely normal, and on LV angiogram, it shows the basal segment hypercontractile, and this patient was diagnosed as Takotsubo cardiomyopathy. So regarding pathophysiology, is very little understood about this condition, and you can see here that there is some with emotional excitement or physical stress, there is some catecholamine surge, which leads to stimulation of limbic system, autonomic nervous system. Then with postneuronal center, there is stimulation of beta receptors. So here you can see that the beta receptors are basically are differential in expression in the LV body. They are less in the beta in the basal zone and more in the apical zone. And because of this, with catecholamine surge, the apex gets hypocontractile. So this is here you can see in the video that there is some brain connection with the heart showing. So this catecholamine surge basically leads to the coronary vasospasm. This is one hypothesis, that it leads to the multivessel spasm. It leads to the coronary microvascular dysfunction. And this is the main cause of Takotsubo cardiomyopathy. Also, the direct myocyte injury is being proposed as a pathophysiological mechanism. So here you can see the differential presentation of various beta receptors. As compared to the basal zone, there is increased beta receptors in the apical zone, and this could be the more sensitive for the catecholamine and can lead to this type of presentation. So basically, the pattern of ventricular wall motion abnormality is unrelated to coronary arterial system, and it appears to follow the cardiac sympathetic supply system. So whenever you look at the echo, if there is more than one artery distribution is shown, then you have to suspect in retrospect if there is any stressors. You have to think about the Takotsubo cardiomyopathy. So regarding management, basically there is no specific guidelines for Takotsubo cardiomyopathy, and you have to at present follow the treatment is as advised for the ACS or acute MI or heart failure guidelines. For chronic therapy, there is some role of ACE inhibitors in its prevention. The beta blocker has not been shown to prevent its recurrent attacks, as we thought that the catecholamine surge can be better be tackled with the beta blocker. Stress management has definitely a role in these patients. So the first line management for these patients, obviously the sedation, anxiolytics, analgesia. If it's relieving the patient, it is going to also relieve the patient's heart as well. And also it is very important to note that if possible, treat these patients with combined alpha and beta blockers to reverse catecholamine toxicity, to avoid an unopposed beta blockade, as we used to treat with the cocaine-induced toxicity. Another thing is, if these patients are hypotensive, these patients are also prone for cardiogenic shock, then you have two questions to answer. If there is LVOT obstruction, if there is none, then you have to treat them with a standard therapy of decreasing preload and afterload with judicious use of inotropes like dopa and dopamine. But The problem arises when there is LVUT obstruction, because you know that if the basal segment is contracting, it can lead to the LVUT obstruction, and these patients are very difficult to treat. And here, for the blood pressure to raise, you have to use the peripheral vasoconstrictor, and because these patients can worsen with the obstruction with catecholamines, you have to give gentle volume resuscitation to decrease LVUT gradient. Also, at times, these patients can require mechanical circulatory support, especially the intra-aortic balloon pump or peripherally ventricular assist devices to decompress LV and bypass LVUT tract. So also, if we have to follow the standard treatment if the patient develops the pulmonary edema. So these are the hospital outcomes. These patients, you can see here that cardiogenic shock can develop in 10% of patients. It is very equivalent to as what we see in the patient with ST elevation myocardial infarction. So if you see here, the pattern of their complication as compared to the Takotsubo and acute coronary syndrome, these patients are prone for cardiogenic shock, non-invasive or invasive ventilation, cardiopulmonary resuscitation, and death is also very, very similar to ST elevation MI. If you look at the short and long-term outcome, these are the patterns of improvement of LV ejection fraction in these patients. Here you can see at the time of admission, and after the patient is being discharged, there is some improvement in ejection fraction, and there is almost always a recovery in the ejection fraction at the 60-day follow-up. So here you can see, if you look at the 30-day pattern of these patients, there is no chance of recovery, but the rate of mortality is quite similar to the ST elevation MI in the range of 4%. So again, on the long-term follow-up, there is 5 to 10 years of data that these patients are also prone in the range of 10 to 20% for the development of recurrence. So one has to be very clear, and they should be advised for the proper stress management, and probably the ACE inhibitors probably are working good for these patients. So to summarize my talk, the Takotsubo cardiomyopathy, it mimics the presentation of acute myocardial infarction. You have to treat them as acute myocardial infarction. It is precipitated by emotional or physical stressors because of abnormal response to high catecholamines. It is more prevalent in postmenopausal women. There are several patterns of LV wall motion abnormalities also have been seen. There are coronary microvascular dysfunction is implicated. Takotsubo is not as benign as previously thought. So with this, I have come to the end of my talk. Over to the Dr. Dinesh. Thank you so much.
प्रकाश,
yes sir.
जब दिल ही टूट गया तो जी के क्या करेंगे?
Yes sir, बिल्कुल.
Thank you, sir. Thank you, sir, for a very lucid presentation over here. And this is something that calls upon for us, everybody who are treating our patients, to be very vigilant that we don't treat every ST elevation to be just myocardial infarction. Even so, if we are having a positive troponin I or other cardiac biomarkers. Just to add on to it, we know there is the universal diagnosis of MI has been given out by ESC, and we know that type 2 MI, almost 66% or 68% of the type 2 MI, which is because of demand supply mismatch, they present as ST elevation MI. So even in those subset of patients, neither thrombolysis nor primary angioplasty will do. And that subset of patients have to be identified. And we know that the only way to identify those patients is a very good clinical history, and if possible, a very rapid evaluation with coronary angiogram. So a normal coronary angiogram in this subset of patient where we suspect that, okay, this patient is having demand supply mismatch, then in those subset of patient, we should never consider for either thrombolysis or primary angioplasty. Another subset where we can do thrombolysis but not primary angioplasty, we often find patients who have got very clean arteries. There is no focal narrowing in those arteries, but we will see that, okay, thrombus is sitting over there. In this, a large thrombus burden is sitting over there. In those subset of patient, I think rather than putting up a stent over there, it is always good to keep that patient on GP2B3A inhibitors like tirufiban or aptifebatide, and the thrombus will just melt away. And if intracoronary imaging is available, then we can see that, okay, the intima is totally normal. So in those subset of patient, again, stenting has no role over there. But yes, if the patient is being considered for thrombolysis, that might work. This subset of patient we very rarely, but we do get quite often in our practice. So over to Gaurav Gupta sir, if any comment.
So I don't have any comments. I think Dr. Shahi sir has covered everything very beautifully. But I'll just, there are some questions in the chat box and I'll just take them up. One is by Dr. Sanjeev Gupta sir. He asked, is there any possibility of heartbreak syndrome or Takotsubo syndrome in the absence of stressors in a psychiatric patient who is already who already has depression or psychosis? Dr. Shahi sir.
Yeah. As I have said that in one largest registry which was published in NEJM, they have shown that 36% of patients have physical stressors, 30% of patients, they have found emotional stressors, and almost 30% patients have no identifiable stressors. So these patients are those patients who are having chest pain, acute chest pain, ST elevation on ECG, troponin raised, but angiogram was normal. But typical stressors were absent in almost 20 to 30% of patients.
So Dr. Sanjeev Gupta sir also had another question. How frequent is this syndrome in your clinical practice?
Yeah, it's very common. I myself have seen hundreds and hundreds of patients. So this is very common. Most of the time we see that there is huge ST elevation, and when we subject these patients to coronary angiogram, there is hardly any stenosis. The coronaries are flowing well and we label them as weak canalized LED. So I have seen a lot of.
It's very difficult to explain to the attendants that we took up for primary angioplasty and we are not doing anything because nothing is required.
Right. Yeah, very difficult.
It's like we have to eat our own words as to what we told them before. Dr. Ajay Kumar Srivastava, pulmonologist, has a question whether the primary management is same in acute myocardial infarction and Takotsubo cardiomyopathy.
Yeah, the primary management is almost altogether very same. And you have to, if there is, if you are going to plan thrombolysis for these patients, I think this is where the situation is tricky, and probably you should send these patients primarily for angiogram, which will probably exclude the diagnosis of Takotsubo versus acute ST elevation.
So I think this is the last question, Dr. Sanjeev Gupta sir. Again, what is the age group where this is commonly seen?
So it is most common in the post-menopausal female. Most of the time, these patients are 50 to 80 years. So it is whenever the females are presenting with ST elevation MI, probably with in the background of stressors, you have to suspect the Takotsubo cardiomyopathy. Especially if there is very decreased ejection fraction with disproportionate decreased rise of troponin. So this is the main tricky things you can get from the outside investigations. I think.
Thank you. I think we'll call it a day with this session now.
Okay. So I think we have come to the end of our sessions, all the sessions, and now we'll open this these sessions for the audience. If there are any questions, they can raise their hand and can ask their questions to all the speakers and chairpersons. So we'll open the session for 5 minutes.
Dr. Sai, hello. Dr. Prakash ji, hello. आवाज आ रही है? Hello.
Dr. Prakash sir, SS.
Dr. Prakash, scientific secretary.
Yes sir, yes.
Sir, ये मेरा question है in Takotsubo cardiomyopathy, which is the most common leads to be seen in the emergency. A patient presented with a chest pain, as you say, like ACS. Which are the most commonly lead has changes in Takotsubo?
Most of the time, this is the entry of MI. You will have to see the V1 to V6 lead, and there are reports which have shown that if the leads of AVR, especially if AVR is positive, then probably you have to suspect these patients for Takotsubo cardiomyopathy. So AVR is also suggestive of left main or triple vessel disease, but in the scenario, like if you are getting a very severe decrease in ejection fraction with less troponin rise, then you have to probably correlate with the background of any stressors like physical or emotional stressors, and then you see the lead AVR along with it there is a rise in the V1 to V6 leads. So probably then you can suspect these patients as a case of Takotsubo.
Okay, thank you.
Hello.
Yes, Dr.
Yeah. My one question to Dr. Dinesh, because he told many times he going for the primary PCI, especially what he telling this young patient who having only the thrombus burden, no stenosis. But it is not a good, I feel no data has there that you leave medically manage this patient on the GP2B inhibitors, because whenever you leave for the medical management, there's this souring of the thrombus will there, and the more LV dysfunction and future risk will be more. So I'm not means I don't know. Dinesh has told you can medically manage such patient, but it is always better to do angioplasty, because if leaving the thrombus in the coronaries, even though the flowing thrombus is a huge burden is there, you should a patient having the ST elevation ongoing angina, you should fix it.
I think the Dinesh was saying that you are right that angioplasty, and he differentiated it with the stenting. He just said that you should not put a stent in a very large burden of thrombus. Probably these patients need first the medical management with thrombus resolution. You can get your angiogram checked, and then after then you, if it is required, then you can put a stent. So
no, but there is no any data, because if you leave the thrombus as such, there is a reinfarction rate is very high. We are not putting thrombus to only just to open the artery. We also prevent the reinfarctions. So I don't feel this was the means if any data is there, Dinesh later he can share it with me, but I don't feel there is any guidelines is recommending either ACCR, ECR, Canadian, even though our CSI. So this management is the only some individualized, because the many patients, the young, you thought this is the flowing, we can leave, but I don't feel this with the scientifically any data is there.
Actually, a case series was presented from Triple M from down south, and they actually had followed up this subset of patients with high thrombotic burden, and they had followed it up with a follow-up angiogram. And if the clot was resolved and intracoronary imaging did not reveal anything in the intima, then they followed up those patients, and their survival and all the major adverse cardiac events were very much equitable with those patients who were actually followed up with primary angioplasty. So I don't know if they would be able to make it to the guidelines, but they do have their own subset of data to support this type of management. And yes, everything is individualized. So
actually this was the case reach, and there is no RCT. If you see the for the RCT, what is the medically managed, like we see the thrombolysis.
Totally agree, sir. Totally agree, sir. Totally agree. And that is why it did not make it to the guidelines, sir. But I think they could not generate enough data to make it suitable for RCT. So that is our fault. We should be doing it more often and see whether we can do a RCT. So once we can do that, we can follow up it with the guidelines.
Yeah. Okay, that's only. And PC Boss has really said that all ST elevation is not required for the thrombolysis or ST elevation. But whenever the diet, it should be within time period, you should do one angiogram with intention for the primary, because ST elevation in the anterior leads, I am always worried if time delay is there, severe LV dysfunction, and is going to long-term life. One kind of this life quality and the quantity both are they going to hamper. So whenever anybody has seen the ST elevation, is in dilemma. Either this can be ST elevation MI because of the occlusive disease, or Takotsubo, or any arrhythmia, or the Brugada. You immediately shift the patient for the as center, where that's angiogram done within the frame time period. I think, Gaurav, what your opinion? Dr. Gaurav.
I'd like to add over here that even all your acute coronary syndromes, please send them for angiograms to the nearest center. We have a large number of centers in Gorakhpur. And if you want to get a primary angioplasty done at 2 o'clock in the night also, hardly 2 phone calls and you'll be able to get it done. Number one. Number two, one thing is, if you have a patient of dilated cardiomyopathy, before labeling it as idiopathic dilated cardiomyopathy, please send to a cardiologist and whether an angiography is required or not. because the line of management changes from there on. If you have the most common cause of cardiomyopathy in our setup is obstructive coronary artery disease. And if we can tackle some of those lesions, the ejection fraction might improve. Quality of life is going to improve a lot. So please keep that in mind. Thank you.
I think
हो गया तुम कुछ हो
Okay, I think if there are no more questions, then probably we have come to the end of our this memorable scientific program. And I now would call upon Dr. V. Agrarwal, sir, Secretary, AIIMS Gorakhpur, and Dr. Shiv Shankar Shahi to propose vote of thanks. Dr. V. Agrarwal.
Dr. BN sir. Dr. BN Agrarwal sir. I think Dr. BN sir is not present here.
No, Dr. BN Agrarwal sir is there.
Oh, BN sir.
इसी शाही सर.
I think on हो गए कई बार सो तबीयत खराब है. आ गए सर BN sir.
शिव शंकर बॉस.
BN sir.
शंकर मेरी आवाज आ रही है शिव शंकर?
आ गए सर. दिख भी रहा है सर, दिख रहा है, बहुत अच्छा दिख रहा है सर.
आवाज आ रही है?
सर बोलिए सर, हो गया. Please give vote of thanks.
Okay. Thank you, Dr. Sai, Dr. Prakash Sai.
Yes.
As a secretary, I am thankful to all speakers, chairpersons, and participants for giving your precious time. और जितने भी लोग हैं यहाँ पे, सबका व्यक्तित्व अपने आप में एक मोती की तरह है, लेकिन जो काम किया डॉक्टर प्रकाश साई ने सबको एक धागे में पिरो के इतने बढ़िया से 3 घंटे तक सबको बांधा रखा, ये एक अच्छी बात है। और प्रकाश साई साहब ने वादा किया था कि हम लोग हर महीने आईएमए की एक बड़ी सीएमई करेंगे, उसी वादे को निभाते हुए दूसरी सीएमई दूसरे महीने में लगातार कर रहे हैं। इनके मेहनत, जज्बे और लगन के लिए तालियां चाहिए। और काफी स्पीकर्स हमारे अपने थे, उनको तो धन्यवाद है ही है। 2 स्पीकर्स डॉक्टर धर्मा और डॉक्टर सुशांत जो बीएलके से जुड़े थे, उनको विशेष धन्यवाद। कोरोना के बाद हम आप लोग को रियल टाइम में आमने सामने सुनना चाहेंगे, इसके लिए हम लोग की रिक्वेस्ट अभी से स्वीकार करिए। और डॉक्टर नागराज सर अपने ही हैं, भले देवरिया में हैं, हम सबके आदर्श हैं, सबके गार्जियन भी हैं। और इस तरह की सीएमई होती रहनी चाहिए। इस सबके लिए धन्यवाद। आप सबको यहाँ जुड़ने के लिए धन्यवाद। थैंक यू
सर। डॉक्टर
थैंक यू सर, थैंक यू। होप नेक्स्ट सीएमई जब भी हो, जब भी वर्चुअल से हम फिजिकल आए तो कोशिश करें कि हमारे आईएमए भवन में हो। सब लोग लगन से लग जाइए और कोशिश करिए अगली सीएमई कोरोना के जाते ही आईएमए भवन में हो। इसके लिए आप लोग सब लोग मदद करिए। बहुत धन्यवाद प्रकाश भाई, ठीक है। होप सारे टीम मेंबर अपनी काम करें, ठीक से करें और ऐसे ही चलता रहे, कारवां आगे बढ़ता रहे। वीर तुम बड़े चरो, धीर तुम बड़े चरो, सामने पहाड़ हो, सिंह की दहाड़ हो, हम निडर डटे रहें। तो इस साथ हम लोग आगे बढ़ते रहेंगे। और प्रकाश साई से वादा था हर महीने हम कुछ न कुछ करते रहेंगे। किस तरह करेंगे सर, आप बस आदेश करिए। हर महीने में 2 मैक्सिमम 2 मिनिमम 1 सीमी का प्रॉमिस है, तो हर महीने कहीं न कहीं व्यवस्था किया जाएगा। बहुत बहुत धन्यवाद सभी श्रोताओं को, सभी आईएमए मेंबर को, और विशेष धन्यवाद बीएलके मैक्स की टीम को जो आए और अपना इस तरह का हम लोग के प्रोग्राम को सक्सेस किए। बहुत बहुत धन्यवाद, बहुत बहुत धन्यवाद सर।
बॉस की जय हो।
Now I request ये शहजाद मिर्जा from BLK to do the next program of lucky draw. Shahzad?
Yes sir. So before that I just want to show this certificate will be issued to each and every member who has participated in the CME. And now I request my colleague Mr. Ajay. Ajay, I am yeah.
Right, sir. Basically, yeah, I'm going to check out the name.
Your network is not good.
Ajay, you are not properly audible. You are not audible.
डॉक्टर दिलचेत विनय सब हम लोग साथी के पढ़े हुए हैं। विनय मतलब डॉक्टर विनय वर्मा।
I think you unmute.
Unmute yourself.
Thank you. You are audible. You are audible, sir. बोलिए अजय sir, बोलिए
I'm audible, sir?
Yeah, you
Yes,
are
sir.
audible.
Yeah. First one is Dr. Manju Kedia, and the second one goes to Dr. Anand Agarwal. Second one is Dr. Anand Agarwal.
Keep this separate, Ajay.
Yes, sir. I'm doing it.
We can't see.
We are counting on your honesty only now because we are not able to. Right.
Third one is Dr. Anju Srivastava.
Dr. Anju Srivastava, right?
Dr. Anju Srivastava.
Right.
Yeah. Congratulations.
Fourth.
Yeah. Fourth one is Dr. Rajan Srivastava. Dr. Rajan Srivastava is the fourth one. Congratulations.
Right. You have to count up to 10. Yeah.
Yes, sir. Fifth one is Dr. Arvind Mishra.
Right.
Dr.
Go ahead.
Arvind Mishra is the fifth one. Sixth one is Dr. Anish Ansari.
Right.
Dr. Anish Ansari is the sixth one.
Can go ahead, please.
Yeah. Seventh one is Dr. Amit Srinath.
Right.
Right.
Dr. Amit Srinath.
Yes.
Right.
Next one is Dr. Manglesh Kumar Srivastava.
Oh, wow.
Right.
Big clap for sir.
Ninth one is Dr. Daud Ansari.
Oh,
okay.
Colleague. Very nice.
And the last one is Dr. Pravan Tripathi.
Okay.
Right. So congratulations to all the.
Congratulations to everyone.
Yeah. Thank you, Ajay. Thank you. So we have
Thank
not
you,
included Dr. Shahi. Sir, we have not included chairperson and speakers in this because we will be giving separately memento and trophy for that.
Okay.
So we will be physically delivering this.
Okay.
Yeah.
Not a problem.
So that's all from our side, sir. Kindly. Yeah.
Thank you so much. And at the last, I would say it was an amazing scientific program because of the speakers, because of the chairpersons, and because of the audience. और आप सभी का तहे दिल से ढेर सारा शुक्रिया अदा इस प्रोग्राम को सफल बनाने के लिए. थैंक यू सो मच. और हमारी एक अनाउंसमेंट है कि नेक्स्ट CME हमारी प्लान है नेक्स्ट फेब में 19th of February, and we'll shortly announce the program details. So thank you so much. I think we have come to the end, and with this note, I think we can end the session. Thank you so much.
Thank you very much. On behalf of BLK, I thank you all. Thank you, sir.
Thank you, sir. Thank you, everyone.
Shujad, I'm going to end the session. You just take the recordings. You have to. Hello.
I think it will take half an hour or so to get it converted into recording link.
Once you will end the program, it will be recorded.
Yeah. Thank you very much, sir. Wonderfully taking care.
Probably I just missed your name there. In
hardly matters, sir. I became your fan. Wonderful event. Kindly end the event, sir, so that.
Okay, I'm ending it.